Ladies and gentlemen, it gives me great pleasure to welcome all of you in this series of webinars I'm organizing as second vice president of the World Federation of Neurosurgical Societies in collaboration with the Continental Association of African Neurosurgical Societies, the CANS, and the Egyptian Society of Neurological Surgeons. Important to mention that we already organized 41 webinars. Among these webinars, there are 10 educational WFNS symposia. Today is webinar number 42, and I'm glad that we are doing this educational symposium in collaboration with the Neuroendoscopy Committee of the World Federation of Neurosurgical Societies. Today's webinar is dedicated to Professor Fred Gentili, who was subjected to an urgent operation. Right now, he is recovering at home in very good condition. In my last communication with his wife, Gina, just a few hours ago, she sent to you this message saying that Dr. Gentili would like to participate. He is still recovering, so please send his regards and let everyone know that he will participate in the next meeting. My message to Fred and Gina and to all of you that I said I would like to thank both of you. I will say this kind message during my welcome note to everyone. Fred saved thousands of lives. He trained thousands of neurosurgeons, and he is loved by thousands of friends and colleagues. Let me welcome all our keynote speakers today. Professor Alberto De Litala, he is Scientific Director of San Carlo Hospital in Rome, Italy, and he's President of the Mediterranean Association of Association of Neurological Surgeons, and he is former President of the Italian Neurosurgical Society. Professor Sergei Gorlijev, he is Professor of Neurosurgery in Berdenko Neurosurgical Institute, Moscow, Russia. Professor Andrea Grotenhuis, he is a professor of neurosurgery, well known in Netherlands, and he is second vice president of the World Federation of Neurosurgical Society. Professor Walid Azab, he is professor of neurosurgery, Ibn Sina Hospital, Kuwait. Professor Luca Massimi is a well-known professor of neurosurgery in Rome, in Italy, and specialized in neuroendoscopy, ventricular, and skull base. Professor Alvaro Cordoba is consultant neurosurgery at the British Hospital in Uruguay. And Professor Samir El-Baba, director of the pediatric neurosurgery, Arnold Palmer Hospital, Orlando, United States of America. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time. Sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. We have very important topics today. We have two sessions. The first session will be about ventricular endoscopy. The second session will be about skull-based endoscopy. Symposium 42, we have registrants over Zoom, 354 until yesterday. And we are doing live stream over the Facebook page of Cancer, which can be accessed through this address. And we are doing live stream over the YouTube channel of the Egyptian Society. And we are doing live broadcast over the Neurosurgical TV. I would like to thank John Bennett for all he is doing for neurosurgery and for our webinars. For all attendees, we are glad to get all your questions and comments. It will be monitored through the chat panel or the Q&A. We are offering this type of certificates. This event is recognized by the World Federation of Neurosurgical Societies, and this certificate is approved by the World Federation of Neurosurgical Societies as well. You can print your certificate electronically. Please don't wait. We are not going to send certificates. You can print it electronically through this link over the screen. Put the username. It's going to be the email by which you registered for this webinar, and this is the password. Please allow just 1 week in order to upload all emails to our system. Important to announce that webinar 43 will be held next Friday at the same time, 2 p.m. Egypt time, 12 p.m. GMT. Is going to be done in collaboration with the Complications in Neurosurgery Committee of the World Federation of Neurosurgical Societies. And we have eminent speakers, Professor Miguel Reis, Testuya Gutu, Professor Frederic Boop, Mishihiro Kuno, Professor William Caldwell, Henry Schroeder, Salman Sharif, Yadram Yadov, and Mazda Torel. Thank you very much. I wish you enjoy our scientific sessions. And before we proceed to our scientific sessions, I am honored to invite Professor Chandra Diopojari, the chairman of the Neuroendoscopy Committee of the World Federation of Neurosurgical Societies, in order to give his welcome speech.
Thanks, Professor Nasser. I'm happy to collaborate and participate in this webinar, which Professor Nasser has carefully arranged. And we are really very glad to have a very eminent faculty today. It's a little bit sad that Fred has not been able to join us today, and we wish him a speedy recovery. I think these kind of educational webinars have been not only educative, but has been also a good place to meet for all of us till we can meet physically again. I think without wasting much time, I would like to get the proceedings going so that we can utilize our time properly. And I again thanks all the speaker and wish you a successful event.
Thank you very much, Professor Diopojari. And actually, I would like to thank you again because Professor Diopojari accepted to give the same lecture and the same topic, which was supposed to be given by Professor Fred Gentili. Thank you very much. Now I have the pleasure to introduce Professor Mahmoud Qorash. He is president of the Continental Association of African Neurosurgical Societies, and he is co-chairman of the Neuroendoscopy Committee of the World Federation of Neurosurgical Societies, to give his welcome note.
Thank you very much, Nasser, for organizing this. And thank you again for dedicating this important webinar to our friend and colleague, Fred Gentili, who, as you have rightly mentioned, is known the world over. And every neurosurgeon who has ever heard of him or met him has been deeply saddened and touched by his plight. However, he is a fighter, and Gina, his wife, has reassured us that everyone's thoughts and prayers and best wishes are being conveyed to him, and he is taking heart and is being motivated by those messages. So when you do get an opportunity, do send him a message. He is very open to being contacted through his wife, Gina. So it's an honor for me to be able to say that CANS, as the Continental President of African Neurosurgical Societies and co-chairman with our eminent co-chair, Professor Dio Pujari of the WFNS Neuroendoscopy Committee, are able to dedicate this particular webinar to our colleague and member of the Neuroendoscopy Committee and the well-known neurosurgeon, Fred Gentili. So with that, I'll hand that back to you. And it's a very busy schedule, so we'll get on with it. And do have Fred in your thoughts and prayers, and we hope to see him at future webinars very, very soon. Thank you very much.
Thank you very much, Professor Mahmoud Qureshi, for this kind welcome speech. Now we start our scientific sessions. I'm happy to introduce Professor Alberto De Letala. He is going to speak about 3D video exoscopy, future and limitations.
Thank you, Nasser. Thank you to everybody. And I'm very happy to stay here with you in distance webinar. I want to remember that Nasser El-Ghandour and me are going to organize the Congress, the 4th Congress of MANS, of Mediterranean Association. We were stopped by COVID pandemic, and we are programming to move the Congress in Cairo on October 2022. You will be informed about it, but all of you are welcome to participate and to be invited. Thank you, Nasser, for your very, very strong organization, and my congratulations. So this afternoon, I want to share with you our experience in 3D video exoscopy. Some of you some of us started to use exoscopy. What is exoscopy? Exoscopy is a kind of microsurgery, and I will speak about it later. This is my hospital, the hospital where I work now. This is the Maria Cecilia Hospital in north of Italy, near to Bologna, and this is the San Carlo Hospital in Rome. So I move between Rome and Bologna. Bologna, in Ravenna exactly, we operate the cranial cases. Yeah. Okay. I have no disclosure to declare, instead of the fact that in Italy we are very famous for mafia. This is our OR with the exoscope. As you can see, the exoscope is a complete substitution of microscope. I couldn't have never mind about it. In my career, my experience, if one of us or one of you has asked me, do you think the microscope will have any substitute ever? I would have said no. Microscope is neurosurgery, and I will never move by microscope. And I have to change, I changed my idea. I want to share with you this discussion. These are the old microscopes between 1929. The industries, the companies started to produce microscope for neurosurgery. The first were lights and then Zeiss with the binocular microscope. Coming in the time with this OPMI 1, I remember that when I was in university, one of the pioneers, Italian neurosurgeon and world neurosurgery, started to use this microscope taken by ENT. And he was very precise in using this. Now we have a beautiful microscope. This is only the example of Kinevo Zeiss microscope, or like many microscope that you know, and everybody of us is using every day. But something is changing, because if you compare the beautiful aspect that have images in the cameras, this is an aneurysm took by by telephone. So the cameras actually are very, very developed. And the developing of the cameras, now we are at 4K, but we are moving very quickly to 8K definition. We will have soon a near retina definition, near human eyes definition. So the progress in this field is very, very quick, and the companies are working hard on this. The Japanese companies is many times that are working with images, in particular Sony and other companies. I had the opportunity to start to use the Orbai exoscope, thanks to my friend Marco Censato, who is the recent past president of Italian Society, who had as test this machine, and he told me, Alberto, try. If you try, you will not use more microscope. It was incredible for me, but I was convinced to try, and since then I want to use Orbai exoscope by Olympus every time. I want to underline that I am not sponsored by Olympus. Believe me, is a changing paradigm. This is one normal case, is of factory groove meningioma, and this is the setting of the OR. Look how comfortable is the setting of the operatory room. This is the exoscope, the arm, the glasses for 3D, and this is the setting. The surgeons can stay both in one side or in a different side. This is a case of aneurysm, and you can see how the definite, very precise, very clear. The colors are really, really very good. And you work in 3D. This video, of course, is not 3D for sharing with you, but if you see this in 3D, you are completely immersed into the cranial space. Very, very nice. And this is the fluorescein to detect, yes, the aneurysm, and to test the blood flow, and is very, very clear. And this is the moment by which the aneurysm was clipped. So absolutely normal microsurgery, but you will see why I prefer exoscope to microscope going on with my discussion. This is another clinoid, anterior clinoidal meningioma, a typical case. There is also a small tentorial meningioma that we did not approach. This is a young woman suffering just for forehead age. This is after the operation. She stayed very well. So we have an incomparable image quality. And my friend Marco Censato usually say, if I say more, I say better. This is the setting, is the chart of the Orbi exoscope, the brace, pneumatic brace, and 3D 4K camera. You can move and you can put in the OR where you like. It's very important that is operated by wireless foot switch. I usually operate by foot switch also by microscope. So for me, according to me, is very important to have both hands on the operatory field and do not move to adjust the microscope, or in this case the exoscope. The volume of the camera that is near to the operatory field is like a can. Differently by microscope. In microscope, you have a lot of space dedicated to the microscope in the operatory field. With exoscope, you just have a very small very small camera that you can move as you like. Of course, it has the autofocus. I don't use autofocus, but I know that some people use that to utilize. And we have all the filters we like in the microsurgery. So the for standard operation, infrared for the fluor, for glioma surgery. Vascular structures. This is another example of intraop angiography. And you see how clear are the details of the vessels. Believe me, better than in the microscope. When you use in 3D, you will be convinced. This is a tumor case by 5-ELA. So normal microsurgery, you have not to change your ability in microsurgery, and you just use the exoscope instead of the microscope. So you have not to change your mind, to change your attitude. This is the operatory setting. Very clear, very useful for residents and for students and for nurses. Which are the benefits of to operate with the exoscope? The principal benefits I can say is ergonomics. So the posture of surgeon is very comfortable because the camera has a rotation, an orbital rotation, and it's very easy to change the position of the camera. And during some operation, I remember the posterior fossa or the retrosigmoid operation, the surgeon is not in a very comfortable situation. In this with this setting, the exoscope setting, the surgeon is very comfortable, straight, standing or sitting. And you know, when you have a long operation like a petrocleival or other operation that take 5, 6 or also 8 hours, is very important to be in a comfortable position. So the main advantages is position and comfort for the surgeon. The second advance is to share with the team all the OR surgeons, students, residents, and nurses are completely involved in operatory teamwork. And you have the possibility of training, educational, and intra-op consulting. So I don't want to lose time with the technical aspects. I want to go quickly to the organizing of the OR. So you can put the if you make a spinal operation, you can put the arm, the C-arc, and the ORBI is very non-invasive in the field. Or if you make a cranial operation, you can put ORBI here or you can put here. So it's not invasive in the operatory room. This is a contrapost position. The surgeon is me looking at this screen 3D, and the other 3D screen is looked by the helper, the second surgery. So we have a surgical efficiency and a facilitating to draw new ways. I think that in the future, the cameras and the precision of 4K view going to 8K view will be very helpful to precision neurosurgery. That is our goal. The limitations are the cost. It costs in Italy about 200,000 euros. It means about like a high quality microscope. And another limitation is convince other colleagues to try to use, because if you have a good thing in your hands, you don't want to change. But if you try this innovation, I trust that you will not coming back. I thank you very much for your attention, and I hope to see you in presence very soon. Thank you to all.
Thank you very much, Professor Alberto Dell'Itala, for this fascinating presentation. Actually, everybody is interested to see this new technology, and maybe we can arrange to have an educational hands-on workshop on endoscope in our meeting together. Thank you very much. I can see that two of our colleagues raising their hands. Already your mics are unmuted. If anybody would like to say any comment or question about presentation of Professor Alberto Dell'Itala, please speak directly. And so now we move to our next speaker. We have also open discussion at the end of each session. Our next speaker is Professor Sergei Gorezhlev from Russia. He's going to speak about the endoscope-assisted microsurgery.
Thank you, dear colleagues. Thank you for invitation for your very useful webinar. And I'm going to share with you my experience with endoscope-assisted microsurgery. First of all, I'd like to say thanks to Alberto, because I thought that I will never change my mind to the exoscope, despite I have the possibility to try it. But I reject that possibility. But now I will think about it. Thank you so much for this very interesting lecture. So, and as for me, instead, I'm fond of endoscope-assisted microsurgery, and I'm going to share with you some of my experience. So, first of all, the general principles are that we may use the endoscope technologies in the water environment or in the air environment. So now we are speaking about the air environment, and here the endoscope-assisted microsurgery means that we use the assistant endoscope, the microscope, and conventional microinstruments. A slightly different implementation is the keyhole neurosurgery, where can we use the assistant endoscope and special para-endoscope instruments. Or to work with two working canal endoscope like LOTA with endoscopic instruments. Yes, so this is the scheme of the endoscope-assisted microsurgery, and this is the scheme of the keyhole neurosurgery. This is our experience. In the majority of cases of brain tumors, of course, I use the microscope, but in some cases, it is very useful to use the endoscope assistance. So the main ideas here is to look around the corner, to look through a keyhole, and at last to do something there. So, as I have told, we use the special endoscope-assisted instruments. First of all, this is the endoscope. It is specially designed for this purpose. It has no working canals, but it has an angled optics and an angled camera. And in some cases, we may use the freehand technique, or we can use the holding system. So the angled microinstruments can be taken from any routine set of microsurgical instruments. It's not very difficult. So this is the equipment of the operating room for endoscope-assisted microsurgery. Usually we have two monitors, at least two monitors, one with the endoscope view, one with the microscope view. The general methodology is the initial inspection of the operating field. Here, usually we use the freehand technique. So during the true operative time, we can use this technique for the removal of the tumor or for the control of the surgical movements, prevention of damage to the surrounding tissues. And we can use this technique for the final inspection for the control of radicality and hemorrhage. So this is the freehand method. You see the microscope and the assistant endoscope in my hands. So, and you can use the holding system. It may be mechanical or pneumatic one. In this case, both hands of neurosurgeons may be used for the removal of the tumor or for any other movements. So now let us go through the different implementation of this method. And usually I tell that every neurosurgeon may elaborate his own indications for the endoscope assistance. As for me, I'm a pediatric neurosurgeon, and I use it for the removal of the brain tumors in children. So, and first of all, the tumors of the chiasmal region and third ventricles. So it may be a good idea to use the endoscope in the suprasellar area in order to look for the suprasellar area and to remove the tumor capsule in this area. Or we can use the endoscope with the angled optics in order to look into the cellar and thus partly use it for instead of the transnasal approaches. So let us look for some video how it looks like in our practice. So this is the craniopharyngioma and the suprasellar, and we use it, the endoscope, for the removal of the endocellular part of the tumor. You see, we use the angled instruments, and we can easily see the contents in the cellular tulsica, and to use the angled coagulation, thus to remove the tumor completely. So quite another situation. This is the GN craniopharyngioma, which is situated under the frontal lobe. And it is not so easy to look at the basal surface of the frontal lobe with the microscope, but it is very easy to look at it with the angled optics and to remove the capsula from this side. So another idea, to use it during the optico-carotid triangle, when we remove the tumor with this approach. You see the carotid artery to the right and the chiasma to the left. And we can really introduce the endoscope into this narrow space and to see the space behind the chiasm. And in this case, we see the remnants of the tumor. This is the gray matter. And now we know the localization of the remnants of the tumor. And then to remove it completely, and now you see the arachnoid after the tumor removal, again, with the inspection of this retrochiasmal space. So speaking about the basal approaches, we can see the pituitary stalk. You see this reddish structure is the pituitary stalk on the most anterior part of the tumor. It is rarely may be seen with the help of endoscope. And this, for example, we can see the anterior communicating artery, the anterior cerebral artery, on the most posterior part of the tumor. Thus, we know its localization and we can avoid the damage and again safely and completely remove the tumor. So as well, we can identify the CSF fistula. And you see, this is the CSF fistula. Of course, with the use of operating microscope, it is quite impossible. So, this is the case of a giant cholesteatoma, the epidermoid cyst. And of course, it was a question how to remove it, not only from the suprasellar space with the operative microscope, but from the frontal lobe, which is very far from the chiasmal region. And in this case, we used the endoscope assistance. I will show you how it was performed. This is the small video. You see, this is the video recorded from the operating microscope. This is the right optic nerve. And you see the typical appearance of the epidermoid cyst. But this part of the tumor was removed under the vision of the operating microscope, but the rest of the tumor was removed with the angled optics of endoscope. You see, this is very typical contents. It is can be removed with the angled suction tube, with other angled instruments, and thus to completely remove the tumor from this very upper region of very far from the chiasmal region of the brain, very far from the brain, from the subfrontal approach. So we use the subfrontal approach, but we remove the tumor from under the frontal lobe, you see. And in the end, you see, this is the surface of the frontal lobe. Okay. So now about the transcallosal approach. So the geometry of the transcallosal approach is very difficult. This is the bone incision, the dura incision. This is the fenestration of the corpus callosum, and this is the most posterior view to the third ventricle. This is the most anterior view to the third ventricle, and this part is invisible for the operating microscope. And while this part may be removed with the operating microscope, and for the removal of the most anterior part of the tumor, we may use the endoscope with the angled optics and safely remove the remnants of the tumor from this area. So, and this is a video demonstrating this surgery. Of course, this giant tumor was mainly removed with the help of the operating microscope. This was the giant chiasmal glioma. But the most anterior part in the third ventricle could not be reached with the routine instruments and under the vision of the operating microscope, but with the usage of the endoscope assistance, we can remove this part of the tumor as well. So you see this white matter in the upper part of the screen. This is the foramen Monro. So we are working inside the third ventricle in its most anterior part. And this part can be seen only with the help of the angled optics. Another situation, this is the aqueductus. This was recorded after the removal of the tumor of the third ventricle. And we can inspect this area as well as we can inspect the most anterior part of the third ventricle. This is the arteria basilaris. also seen after the removal of the endosuprasellar craniopharyngioma, which destroyed the floor of the third ventricle. But now we see that no remnants of the tumor in this area are left. So the tumors of the lateral ventricle. And in children, these tumors are, the majority of these tumors are the choroid plexus papillomas. You know that these tumors has a very rich blood supply. And thus, the idea is to see the feeding arteries before the removal of the tumor in order to know their localization. And for example, you may see on this video that we have used the transcallosal approach. We penetrated with the endoscope. Now we are in the lateral ventricle. Then we move our endoscope more deeply. We see the foramen Monroe, the choroid plexus, the choroid plexus papilloma. Even we may reach the third ventricle, as it is now shown. And now we know that the floor of the third ventricle is free from the tumor, and the tumor is only in the posterior part of the third ventricle. And thus we know its localization and can safely remove the tumor. Another example of the same situation, this is the cavernoma of the lateral ventricle. And even on the MRI, you can see the very large feeding arteries which come to it. This is the choroid artery. And now we move with the endoscope through the normal sized lateral ventricle. And in the depth, we see the choroid arteries which come to this cavernoma. And we know their position, and we can cut the feeding arteries safely and not to damage them. And now about the tumors of the posterior fossa. So what are the ideas? So the main idea is either to look at the possible remnants of the tumor under the cerebellar vermis. So it may be in cases of medulloblastoma, because it is infiltrative tumor, and we can leave some remnants in this place. Another idea is to look thoroughly, for example, for the gliomas of the brainstem, which penetrate into the fourth ventricle, and to look at it from different parts of it. So, and now we can see the video demonstrating this idea. So this is the angled optics, and we see this white reddish matter. This is the normal appearance of the cerebellar vermis. We see no tumor remnants in this area. So, and this is another. This is another example. This is the large tumor of the posterior fossa, penetrating into the hemispheres of the cerebellum. And you know that using the median approach, it is not so easy to look to the right and to the left, but with the help of angled optics, we may see these areas and to safely remove the tumors from these parts. So, and this is the most superior part of the tumor. You see the tentorium, and again, we can look under the tentorium. We can look to the cisterna ambiens and to check the operating field in this space. And very short examples of another implementations of this method. This is the view of the supraorbital lateral approach. Pay attention to the dimensions of the bone incision, skin incision, and dura incision for this approach. And this is one of the examples how to use the this technology for the removal of, for example, the craniopharyngioma. This is the right optic nerve. We have we have performed the subfrontal approach, very narrow, with the help of operating microscope. Then we took it away, inserted the endoscope into the operating field, and the rest steps of surgery we performed only under the vision of the endoscope assistant, with endoscope assistance. This is the pituitary stalk. You have seen it very clearly. This is the carotid artery, and you see we have removed the suprasellar part of the tumor, and even we can look inside the cellar if we change the optics to the opposite one. This is a cosmetical result, and this is the most smallest part of my report. This is only one example how to use the bimanual technique in the air condition. We used the Lotta with 2 working canals for the biopsy of the germ cell tumor. You know, this is these tumors have very rich blood supply. So we performed the subfrontal approach as well. And then we used the 2 instruments for the biopsy. We used even the suction tube to perform the suction of the from the blood. We can irrigate and aspirate. We can irrigate the operating field. We can aspirate the blood, and we can safely perform the biopsy only using the air environment without no fluid. So this is our experience, and there is no conclusion, because as I have told you in the beginning of my lecture, every neurosurgeon, to my mind, may elaborate his own indications, and I hope that my experience will help you to find your own way to the endoscope assistant microsurgery. Thank you.
Thank you, Professor Sergey, for this great talk. Actually, you presented very difficult cases, and you are doing a great job. And I have the pleasure now to introduce Professor Hisham Bassiouni. He's well-known neurosurgery practicing in Germany. He is going to be the moderator of this session with myself. I think we have some questions for Sergey in the chat panel. Hisham, are you here?
I'm here, and I just said hello, everybody.
Thank you, Hisham, for joining. Thank you. Thank you. Thank you very much. Now, Hisham, I think we can. I can see some questions in the chat panel. I would say the same. The first question, Professor Sergey, very difficult cases. In fact, I'm asking about the craniopharyngioma cyst reaching the prepontine cistern. How can we reach this part of tumor by endoscope? Do you need to drill the clivus, or you can reach it with angled scopes without drilling?
No, yes, thank you for this question. No additional drilling. So the main idea of the endoscope assistant microsurgery is the usage of the angled optics. It may be about 30 degrees, it may be 45 degrees, it may be even 90 degrees. So you can look at any part of the operating field. Thus, you can avoid additional drilling. This is one of the main advantages of this method.
Okay, this question was from Mariam Ghanem. She's an Egyptian neurosurgeon. We have another question, Sergey, from Dr. Harshad Parish. He asked, when the endoscope is applied, if tumor starts bleeding, how you control, and who holds your endoscope during tumor dissemination? Simply is asking what you are going to do if bleeding occurs intraoperative, and if you are using a freehand endoscopy or fixed, and who is holding the endoscope for you?
Yeah, thank you. So in the very beginning of my report, I have told that there are 2 ways. So in the beginning of the surgery, if we want to look around the operating field, to look at the deepest part of the operating field, to find any vessels or to find any parts of the tumor, to know their location. So we can use the freehand technique. So, but during the, and the same in the end of surgery, for example, in order to know the site of the bleeding, so we can use the freehand technique. But during the tumor removal, we use the fixation of the endoscope. You may use it, this is well-known devices. It may be a mechanical or pneumatic artificial hand. So, and we can fix the endoscope in one part of the operating field. So we can change the position of this endoscope during surgery several times. In order to, for the better visualization of the different parts of the operating field, and in order not to close the view of the microscope. So this is the first question. The second one concerning bleeding. So you see, this is endoscope assistance to the microscope. So in all these cases, we use either the routine approaches, subfrontal, pterional, or some other one, or we can use, as I have told you, the keyhole approach. But in any case, we may use the endoscope at any time of surgery. So if we have bleeding, we can take we can take our endoscope out of the operating field to take microscope and to proceed with the routine procedures to stop the hemorrhage.
Sergey, another question over the chat panel. One of our colleagues, he asked about the tumor in the corners. How can you reach these parts of the tumor by micro instruments without drilling? He understands that you are using angled endoscopes, but he's asking about the instruments, what you are going to do in such case.
Yeah, so I think you mean, so if we operate around the corner, yes, so yes, the first part is to use the angled optics, and the next point is to use the angled instruments. So the angled instruments are included in any microsurgical set, for example, a Sculap set or any other. So I don't know what for they are included in any microsurgical set, because the most useful implementation is to use these angled instruments in the situation of the endoscope assistant microsurgery. The only one instrument which has not been found in the routine sets is the suction tube. So, and only this instrument has the straight working canal. So, and for this purpose, I asked my friends at the factory to curve it. So, and this is the only one instrument which I has elaborated, but it is not so. It's not so difficult to curve it in the home conditions and then to use in your practice.
Okay, Sergey, this is the last question in the panel. I'm trying to answer all questions really because we are doing these webinars for young neurosurgeons. I know that we are far behind the time schedule, and we will have another discussion at the end of this, of each session, panel discussion. But this will be the last question. Somebody is asking, do you do endoscopic third ventriculostomy routinely after tumor excision?
No. So in the majority of cases, we try to remove the tumor completely. So, and I think that you speak about the third ventricle tumors. And in the majority of these tumors, in these tumors, you see, we can speak about the ETV because these tumors occupy the floor of the third ventricle, and this is the natural ETV after the removal of the tumor. In cases of the pineal tumors, yes. So if we use the endoscope for the biopsy of the pineal tumor, then we may proceed with the ETV because we use the same operating field, the same corridor. This is the only one situation when we use both surgery and ETV.
Thank you, Sergey. Please stay with us. We'll have another discussion among the panel. Okay, thank you very much. Now I give the mic to Hisham Basuni to complete moderating the session.
Yes, thank you very much. And thank you for inviting me to join this traditional webinar series, and also by now very famous, worldwide very famous webinar series, very sophisticated cases. And thank you very much, Professor JJ, for this your presentation. I just saw yours. I joined a bit late. So I have the honor to introduce Professor Mahmoud Qureshi, and you know each other by the webinar series by now from Kenya, and who gives us the presentation of ETV in the treatment of childhood hydrocephalus. Please.
Thank you very much, Sham. It's a pleasure to see everyone, and thank you, Nasser, for the sterling job that you are doing on behalf of the Continental Association and, of course, the Neuroendoscopy Committee. So my job is to bring down the tempo a little bit, as a lot of our participants from across the continent will be listening to this talk. I wanted to share with them the principles of doing endoscopic third ventriculostomy in hydrocephalus. And if I may just share my screen. Once again, as we mentioned earlier, we are dedicating our talks to our friend Fred Gentili. I believe you are able to see my screen, Nasser, and everyone.
Yes.
Yes.
Okay, so we had already done the introduction and the dedication to our friend, so I will move on to the subject, which is essentially on the role of endoscopic third ventriculostomy for childhood hydrocephalus. And essentially, the problem of childhood hydrocephalus is a significant one all across the world, but it seems to be a particular affliction of low and middle income countries for various reasons. And in our sub-Saharan region, this is of particular significance. This is just an image of a mission that's being conducted just for hydrocephalus. And as you go in, the room is full of children with hydrocephalus seeking treatment. We'll just, for the benefit of our younger audience, just go very quickly through the history. It started in 1910 with Lepinas with a cystoscope, then refining it to calling it a ventriculoscopy, and used an endoscope to perform choroid plexectomy. Mixter in 1923 is recorded as having performed the first ETV in a child with congenital hydrocephalus, and at that time used a urethroskop and a probe to do that. But the popularity of endoscopic third ventriculostomy then waned because of the high mortality, large cumbersome instruments, poor magnification and illumination. You can imagine doing this in the 20s. It's unbelievable that they even considered doing it, but those are the pioneers of our profession. In mid-1980s, because of the popularity of minimal invasive neurosurgery, endoscopic third ventriculostomy and neuroendoscopy started to get a renewed interest. And then, of course, with better cameras, better light sources, improved resolution, this was an important step towards the rediscovery of neuroendoscopy. And of course, the cameras, the holders, the endoscopes are key to our management. There are two types, as everybody knows, but again, for the benefit of our younger audience, we'll talk about the advantages and disadvantages of each. I have been using the rigid endoscope and only very, very occasionally use the flexible one because their servicing is a problem. They do tend to get into dysfunction very quickly, and in our setup, it's not easy to replace them. So the rigid one is a little more stronger and less likely to get damaged. The advantage of the rigid one, as everybody in this audience knows, but particularly for the younger ones who wonder why, if you are going to invest in an endoscope, you should invest in one or the other, then perhaps the rigid one is the one to go for because it has better image. When you are starting, you want to see everything very, very clearly. It has higher resolution. It gives you a broader view. The color definition is better and transmits the light much better than the flexible one. But the advantage of the flexible one is, of course, that you're able to steer the endoscope, and that's why it's called a flexible endoscope. The disadvantage of the rigid one is that you might damage structures around you if you are trying to maneuver and look at different sites. And but the disadvantage of the flexible one, again, contrary to the rigid one, is it's a poor image, less color definition, poor lighting, and the selection of the scopes and instruments is obviously limited with flexible scopes. You get a narrower view and a smaller working channel. So the indications for ETV, primarily in hydrocephalus, is the most common one is the primary aqueductal stenosis, pineal and tectal tumors causing hydrocephalus. And in this scenario, one does a one-step procedure, as was just described earlier. You do the biopsy and you do the ETV at the same time. Of course, the risk has been mentioned. There are case reports of germinomas occurring along the ventriculoscope tract, and but it is a workhorse for such tumors. The less common indications for ETV are the idiopathic stenosis of the foramina of Magendie and Luschka, and several case reports have been mentioned where one can go in and manage to treat the hydrocephalus successfully in this sort of scenario. Posterior fossa tumors will give us hydrocephalus, and you can do endoscopic third ventriculostomy prior to the posterior fossa surgery, and this significantly reduces the risk of postoperative hydrocephalus. And patients who have repeated shunt infections, the problem is the hardware. You really want to remove that hardware, and it's one of the less common but important considerations to do an endoscopic third ventriculostomy in the sort of setting. Then there are the uncommon indications, the isolated lateral ventricle with hydrocephalus. In this scenario, one does fenestration of the septum pellucidum in combination with the endoscopic third ventriculostomy. Dandy Walker cysts, there are reports, of course, one can perform an end of ETV and place a stent from the third ventricle to the posterior fossa, but these are less common indications and are fraught with problems of maintaining the stents in those sort of situations. So, so in summary, the highest success rates in ETV are seen with acquired aqueductal stenosis and tumors that obstruct the CSF flow. The intermediate success of between up to 75% are seen in previously shunted meningomyelocele with hydrocephalus, congenital aqueductal stenosis, the arachnoid cysts, Dandy Walker cysts, recurrent shunt infections. And the success of ETV is least in post-hemorrhagic hydrocephalus and post-infectious hydrocephalus. And in sub-Saharan Africa, that's one of the more common problems that we face. Quite a lot of our hydrocephalus is post-infectious. And then in the setting of a meningomyelocele. The procedure itself, for those who are contemplating doing it, are in the early part of their training or careers, is to try and essentially fix the head, because the last thing you want is, you can fix it with just a tape across the forehead. The last thing you want is under the drips, the head having moved and you're not aware, and your orientation has all but disappeared. So one makes a curvilinear incision in the coccus point, about 11 to 12 centimeters posterior to the nasion, or 1 centimeter anterior to the coronal suture in the mid-pupillary line. The right side is typically selected unless pathology dictates a left-sided approach. And the basic operative technique is to determine the entry point and enter the ventricular system, find the foramen of Monro, find the foramen of Monro, and inspect the floor of the third ventricle, perforate the floor of the third ventricle, enlarge the perforation up to about 5 millimeters, and inspect the prepontine system. The position of the head, we'll just go back and just look at it. You really want to put the head in a slightly flexed, so-called sniffing position. This is to allow the air that is going to be inside the ventricle to have an outlet and not get entrapped in the ventricle. The dura is incised in a cruciate fashion. A sheath of usually a 14 French sheath is passed into the lateral ventricle at about 4 to 5 centimeters. And then the endoscope is then passed through this sheath to identify the thalamostriate vein on the lateral edge. And as it meets the choroid plexus at the foramen of Monro, that's where you will find the foramen. You navigate through the foramen, taking care to avoid bruising or injuring the fornix, and identify the floor of the structures in the floor. So essentially, as you go in, you see the thalamostriate vein, and you follow it where it meets the choroid plexus is where your foramen is going to be. You look at the foramen and you enter into the foramen and inspect the floor of the third ventricle, and then perform your ETV, and then go into the prepontine system to ensure that your membranes are not occluding the flow of CSF. A continuous irrigation with warm Ringer's lactate is usually recommended. Some people use saline, but it can have problems with change of sodium levels in the child. Ventriculomegaly in patients who have undergone ETV does not decrease as quickly as it does in shunted patients. So be aware that you don't diagnose a failed ETV simply because the ventricles have not reduced in size. Therefore, you wait several weeks, 6 to 8 weeks, rather than first or second postoperative day to assess whether the shunt, or the ETV is working. This is the view that one gets of the floor of the third ventricle, and you're basically trying to look for the mammillary bodies, and you've got the infundibular recess, the tubercinarium, and the mammillary bodies, and you really want to get your stoma somewhere, well, in the distance between halfway between this slide and your your infundibular recess. So the so-called triangle, where you essentially draw the triangle here and go midway, that's where you want to do your stoma. And once you, and the most lateral one should go is 11 o'clock or 2 o'clock. Otherwise, you risk damaging the third nerve on the extremes of lateral side of this stoma. The correct point for the third ventriculostomy, as I mentioned, is the center of the so-called hypophysiomammillary triangle. Multiple methods exist for perforating the floor. The most reliable one is just a blunt probe. The monopolar can be gently pushed through. You can use the Fogarty balloon to do that. Some have advocated electrocoagulation. I have advised against this because anywhere near the basilar artery, any coagulation can actually result in damage. So I tend not to use electrocoagulation in that area. Some have used lasers, ultrasonic probes have been used. Once the stoma has been made, then you dilate the area using a Fogarty balloon catheter. Essentially, one can use the blunt forceps to enter and open up the stoma before one inspects the prepontine system. One must explore the prepontine space and open the membranes of Lilliquist. And I say membranes because one must be aware that there are two membranes. One is the diencephalic and one is the mesencephalic component of the Lilliquist membrane. And quite often in the earlier stages of one's career, you go through doing endoscopy, you go through the floor, you see a membrane, you perforate it, and voila, you think you've done the job, but look for that extra membrane and make sure that you've seen both. For example, here is the view that one gets. This is the membrane of Lilliquist, and that's the diencephalic, the front part of the Lilliquist membrane. Then you visualize the perforating arteries, the third nerve, and basically the structures around the basilar artery, and may be absolutely certain that there are no membranes that are still remaining. So you basically look for both the diencephalic Lilliquist membrane and the mesencephalic portion of the Lilliquist membrane, which is coming from posteriorly. And once you've entered, you will then have a very good view of your basilar artery, your pontine arteries, your posterior cerebral arteries, etc. But where ETV fails is when one has not done an adequate perforation through both portions of the Lilliquist membrane. And the favorable features for endoscopic third ventriculostomy are, the clinical ones are age above 6 months or at the time of the procedure. The child is older than 6 months. Children who have been irradiated for any other reason are not very good candidates. There has been no meningitis or hemorrhage. And in terms of radiological features, one must be convinced that this is an obstructive hydrocephalus, that there is no aqueductal flow void, there is a thinned floor of the third ventricle, which is bulging downwards. That's a sign that your ETV is likely to succeed. The outcomes that one looks out for is shunt independence, change in ventricular size over time, as we mentioned, and patency of stoma, as if one can get an MRI done. It is less common in areas of our sub-Saharan Africa to get MRIs for all the children, but it would be obviously a desirable investigation. Essentially, the outcomes are best now with obstructive hydrocephalus, and the older the children, the better the outcomes. In adults, one sees early postoperative improvement within 2 weeks after ETV, and one can look at MR images and confirm that this is working. But there's no predictive value of reduced ventricular size on MRI. However, if you give it time and there is reduction in the ventricular size, that begins to tell you that you're going to have long-term success. In pediatrics, one sees that the younger the child, the less likely the success rates, but anyone over 2 years of age, the success rates begin to get higher. We won't go through this busy slide, but again, it's the same message. Long-term outcomes have been looked at as to what is the reliability of ETV, and essentially surgical successes are likely with ETVs up to about 90%. So one must always be aware that you may not necessarily have a very long-term favorable outcome, but 90% is what is expected. Reliability of ETV after 1 year was stratified according to age. Doing ETVs from in the first month of life, you get about a third being successful. 1 to 6 months, 50% success. Up to 6 months to 24 months, which is the ideal period, you get 3/4 of them being successful. And after the age of 24 months, they're more likely to be successful. So essentially the message here is, yes, do try your ETVs, even in the younger children, but do warn the parent that we may end up with a shunt if it doesn't work. Evaluating the patency of ETV, this can now be done with CNFA's contrast MRIs, which is able to detect flow across the ETV, and fast spin echo on a T2 MR sequence will also show you the patency of your ventriculostomy. So essentially what one is looking at is restoration of pulsatile motion of CSF circulation. The stroked volume registered at ventriculostomy should then be maintained over time. And again, we've mentioned earlier, there's no relationship between the ventricular size and a diagnosis of a successful ETV. The other problem that we have in our settings is the anatomic anomalies that one sees, and one does the ETV. There are various anatomical abnormalities, from absence of septum, no corpus callosum, enlarged fornicial columns, interthalamic commissures, and large floating choroid plexuses, very narrow space between the dorsum cellar and the basilar artery, and sometimes there's just no floor of the third ventricle, and all one sees is an arachnoid membrane. These anatomical abnormalities imply that your surgical operating time might be increased, and the morbidity also increases because you're more likely to cause damage to structures, and this then potentially impairs the success of ETV. The complications that one must be aware of or look out for is intraoperatively. One can get the child going into a bradycardia, and so your anesthetist must be very aware that during the irrigation process, particularly if the fluid is not adequately warmed, you might get into some of these problems. A choroid plexus injury can happen, giving you intraventricular hemorrhage. But in terms of the smaller hemorrhages, most of these settle if you continue to irrigate, and they will settle. The disaster is when you get the basilar artery injury. Although the incidence is low, one must be very careful when entering into the prepontine system. Postoperatively, the problems that can happen are hypothalamic dysfunction, pneumocephalus, subdural hygromas, hematomas, infection, CSF leaks from the wound, and impairment of memory. And that's what happens if your fornix was to be damaged. In the delayed complications, the sudden deaths have been reported because of a late failure of ETV. That can happen. So it's not the fact that your ETV has been functioning for 6 months that you can discharge them from your clinics. It's advisable that they do maintain a follow-up, because late failures of ETV have been known and can result in sudden deaths. Seizures are a rare but important complication. So from CSF leaks to meningitis to hemorrhage to hypothalamic injuries, all have been reported, and one must be aware of these possibilities. The surgical factors that correlate with failure of ETV is if one unfortunately has an intraoperative significant hemorrhage during ETV, presence of hemosiderin deposits when doing the ETV, if one sees a double floor of the third ventricle or thick prepontine adhesions, thickness of the floor of the third ventricle, all these suggest that your ETV is less likely to be successful. The incidence is most in the first 1 to 2 months, which is referred to as early failure of ETV. And then there is the delayed failure, which results from non-absorption of arachnoid granulations despite seeing a good MR flow. And essentially, the thinking is that your arachnoid granulations are not able to absorb your CSF. And of course, the stoma can close from gliosis in about 10% of patients, resulting in ETV failure. Failure of ETV in infants, those who have had repeat ETVs, what one sees is that there's reclosure of the stoma or narrowing of the stoma itself, and the patent ventriculostomy stoma with new arachnoid membranes having developed in the basal cisterns, which were not present in the time of the first ETV, have also been reported. So all these may result in failure of ETV. So again, those who, when one has looked at these failed ETVs and gone back in, you see that there's been scar tissue that might have formed, or the floor was apparently never entered properly, or there's a very tiny stoma, or incomplete penetration of the membranes, or blood clots occluding the orifice. And in these cases, if one does a repeat ETV, you're more likely to succeed. So there is a role of doing ETV, a repeat ETV, if one suspects that it's not adequately functioning. So essentially, the purpose of this slide is that ETV after shunt failure is more likely to fail, although we do tend to do ETVs in cases of shunt that have not shown that have become non-functional, and the child is over 6 months. You can go in and do an ETV, but be aware that they're more likely to fail in that sort of scenario. Choroid plexus cauterization is a new adjunct that was introduced by Benjamin Wolf in Uganda and is now becoming popular. And I know that Samir is going to be on this webinar, and would be interesting to hear his thoughts. I personally don't do CPCs, as I said, but it's something that is gaining popularity and is showing success of increased success of ETVs particularly in the subgroup of post-infectious hydrocephalus and meningomyelocele that we see in our setting. So essentially, as Ben Wolf has said, when one combines ETV with CPC in the setting that I've described, the success rates do increase. There is the ETV success score, which essentially is a very useful guide on when talking to parents, and it's dependent on several items. One of them is age. Under 1 year, the score that one gives is 0 points, and above 10 years, you score 50 points. Essentially, 1 to 6 months, 6 months to 12 months, 12 months to 10 years, you are more likely to have a successful ETV. The other item that is part of the ETV success score is etiology. If it's post-infectious, then it's very unlikely that your ETV will succeed. But if it's aqueductal stenosis or a tectal tumor, you score 30 points and you're more likely to get ETV, your successful ETV. Then there is a previous shunt. If there has been no previous shunt, then you have a higher likelihood of success. If there is a previous shunt, particularly in a post-infectious setting, one scores 0. And essentially what this means is when you score 0 to 30 points, the likelihood of success is 0 to 25%, 40 to 60 points, it increases to 45 to 55%, and 70 to 90 points, the likelihood of success is 70 to 90%. Essentially, with age, etiology, and history of infection, if you combine that, that is likely to give you the likelihood of a successful outcome. And it's a useful guide to discuss with the parents of a child when one is advising on ETV and whether it is going to be successful and what are the chances that it will be successful. And each parent must know that there is no 100% success in this, and the likelihood of a repeat ETV or a review and a possibility of a shunt remains a strong possibility. So the message is that ETV success score ranges from 0 to 90. The number approximately translates into the percentage chance that an ETV will be successful at 6 months post-procedure. And taking into consideration the anatomical variations that occur in childhood hydrocephalus, ETV success score provides a valuable guide in predicting the success and is helpful in providing the informed guidance to parents, as I said, by their care provider, the neurosurgical team. And with that, I'll thank you once again, and I'll thank Nasser for the opportunity to share this fairly basic talk for purposes of learning of our young neurosurgeons across our continent and beyond. Thank you so much.
Thank you very much, Professor Mahmoud Qureshi, for a very important presentation. Actually, as I'm going to say in my talk, I'm more concerned about basic procedures than complex endoscopic procedures, because for all young neurosurgeons, if you know how to do endoscopic ventriculostomy properly and you acquire a good learning curve, you will be able to do any endoscopic procedure. Hisham, would you like to proceed now?
Yes, so I introduce you, my friend Professor Nasser, for the topic of ETV in treatment of posterior fossa tumors in children. And thank you, Professor Mahmoud, for this excellent overview. Thank you very much.
Thank you.
Thank you very much for introducing me, Hisham. Let me start by this introduction. I have an important publication in the Neurosurgical Focus in March 2020, which evaluates the challenges or obstacles facing neurosurgery in Africa. Among these obstacles are the lack of resources, shortage of facilities and basic equipment. Definitely there is a problem in training and the rapidly increasing population. What about pediatric neurosurgery in Africa? There is very fast increase in population in Africa, much more than any other continent. Obviously, this is reflected in an increase in the pediatric age group. The World Bank estimates that 44% of African population is under 14 years old. This leads to an increased incidence of pediatric neurosurgical problems like hydrocephalus and meningomyelocele. This shows the pediatric hospital of Cairo University, to which I'm affiliated. It had been constructed on 1983 as donation from JICA. What is JICA? This is Japanese International Cooperation Agency, which had been constructed in 1974. This is the headquarters in Osaka. And this organization is concerned about global development, and it offers many health and education programs and projects. We'll speak today about endoscopic third ventriculostomy in the treatment of obstructive hydrocephalus due to posterior fossa tumors in children. Hydrocephalus associated with posterior fossa tumors in children is definitely a life-threatening condition. Hydrocephalus is one of the main factors influencing the outcome. Children are very sensitive to intracranial pressure elevations, and so its treatment should have the highest priority before considerations are given to the surgical approach of the tumor itself. Authors claim that 1/3 of children with posterior fossa tumors require post-operative cerebrospinal fluid diversion. As we all know, the classic management of advanced hydrocephalus due to posterior fossa tumors in children is temporary cerebrospinal fluid diversion by putting an external ventricular drain prior to definitive tumor resection. However, an important question still arises. What are you going to do if you receive a patient with posterior fossa midline tumor associated with acute severe hydrocephalus, and you do not have access to perform urgent tumor excision, either due to lack of facility or due to lack of expertise? You don't have senior neurosurgeons, or due to waiting patient list and so no available operation room, like in many centers in sub-Saharan Africa. Our objective in this study is to evaluate the role of endoscopic third ventriculostomy in the management of these patients and whether it is more superior than ventriculoperitoneal shunt. Of course, the video of the procedure will not be much exciting because it's a classic procedure, as you all know. However, it's important to stress that many authors claim that tumor will displace the brainstem forward, and this obliterates the interpeduncular cistern, which makes endoscopic third ventriculostomy technically difficult or impossible. Our results did not confirm such claims. We are able to perform endoscopic third ventriculostomy easily and successfully in all our patients. This table shows the preoperative clinical findings among our cohort of patients who were divided into two groups according to the procedure adopted to treat the hydrocephalus. And it's important to mention that all our patients had severe hydrocephalus. This shows surgical findings in both groups, and as you can notice that there is an important difference in the duration of surgery. And in the duration of hospital stay, ventriculostomy was superior. And it's important to mention that medulloblastomas and ependymomas were selected because they are the most vulnerable to produce obstructive hydrocephalus among all posterior fossa tumors. And in order to have homogeneous sample of patients, this table summarizes the morbidity and the mortality. Also, you can notice that the incidence of morbidity is statistically more significant, highly significant, with highest incidence among the shunt groups. Let me show you some cases. This is 3-year-old girl with ependymoma and advanced hydrocephalus. And as you can notice, the periventricular CSF permeation denotes that hydrocephalus is occurring acutely. Post-operative CAT scan 3 days after endoscopic third ventriculostomy showing considerable improvement in the hydrocephalus as evidenced by the reduction in size of the ventricle, the resolution of periventricular edema and opening of the subarachnoid space. 5-year-old girl with medulloblastoma compressing the fourth ventricle with advanced hydrocephalus, post-operative magnetic resonance imaging showing marvelous improvement. 5-year-old girl with medulloblastoma compressing fourth ventricle and advanced hydrocephalus, post-operative imaging showing considerable improvement. 6-year-old girl with ependymoma involving the fourth ventricle with extension into the lateral recess and the cerebral peduncles causing marked hydrocephalus, post-operative imaging showing marked improvement after 3 days from the ventriculostomy. This sagittal view magnetic resonance imaging is very interesting because here you can see clearly the perforation which had been done by the endoscope in the floor of the third ventricle, communicating the third ventricle with the interpeduncular cistern. This patient had a huge medulloblastoma, and on the right side, it shows the image before and after ventriculostomy. This flow velocity graph shows systolic, diastolic, unidirectional flow of cerebrospinal fluid from the third ventricle to the cistern. On the right side, axial flow-gated magnetic resonance imaging showing cerebrospinal fluid flow void at the site of the ventriculostomy. Intraoperative findings during tumor removal 1 to 2 weeks after the ventriculostomy, it was clear that the dura was lax, what we call it slack posterior fossa. Ventricular tapping was not necessary. Cerebellar retraction was easy. Good tumor exposure and dissection was possible in all patients. This table shows that there is a statistically important difference or high difference between the incidence of post-operative failure between both groups. Actually, all the patients operated by endoscopic third ventriculostomy remained shunt independent among the mean duration of follow-up of 27.4 months. Kaplan-Meier survival curve shows more decrease of cumulative survival in the shunt group, higher survival time for the ventriculostomy group, and the log rank test was highly significant, p less than 0.01. I can attribute the good outcome into 3 reasons. In such cases, the hydrocephalus is acute, and this makes the floor of the third ventricle very thin and very easily to be perforated by the Fogarty. This in contrast to patients with myelodisciasis, where the floor of the third ventricle is usually very resistant to perforation, and it's tough in most of the patients. Anatomy of the third ventricle is undisturbed, and you can very rarely notice any anatomical variations. And the subarachnoid space of these patients is normal with very good cerebrospinal fluid absorption capacity. Actually, the endoscopic third ventriculostomy is superior than the ventriculoperitoneal shunt. There is no incidence of shunt dependency. There is no risk of seedling. There is no risk of upward herniation. The procedure is performed under vision, and it's minimally invasive. What are the indications? I recommend doing endoscopic third ventriculostomy for the treatment of obstructive hydrocephalus. Secondly, to pursue fossa tumors in children in two conditions: high risk children of developing postoperative hydrocephalus. These are the children who are younger than 3 years of age. As reported in many publications, 80% of these children at such age need postoperative shunt. And with the presence of preoperative marked hydrocephalus. The other indication is when you don't have the feasibility of doing emergency tumor resection in low resource settings due to lack of required facilities, lack of experience with personnel, or waiting operation list. We published our results in the child nervous system, and it's clear that I recommend endoscopic third ventriculostomy while dealing with these patients because it is safe procedure, it's effective, it's easy, technically it's easy, minimally invasive, and you are working under vision. It's physiological procedure, and there is no any kind of shunt dependency. It is a rapid procedure, just takes 15 minutes, and it's low cost. When I joined the neuroendoscopy committee of the World Federation, I sent a proposal to the chairman, Professor Chandra Dupujari and Professor Mahmoud Khorashi. My proposal was saying, my aim is to make endoscopic third ventriculostomy simple traditional procedure that can be performed by junior neurosurgeons, same like ventriculoperitoneal shunts. I think we have to work hard in order to train as many young neurosurgeons as possible so that they can perform endoscopic third ventriculostomy with elaboration. We are offering scholarships. We are organizing endoscopy courses, hands-on workshops in Egypt many times each year, whether basic or advanced courses, and all attendees or all participants are welcome to join. And this is my email. And we are offering scholarships concerning food and accommodation to candidates from Africa and developing countries. This is the WFNS hands-on workshop organized in March 2018. This photo shows the president of the World Federation of Neurosurgical Societies and myself, and surrounded by the faculty and African trainees. Another workshop performed in Egypt, March 2018. And Luca Massimi is contributing to this hands-on workshop. As Alberto said in his lecture, that we are organizing together. Alberto is the president of the Mediterranean Association of Neurological Surgeons. We have an important congress which is going to take place in Egypt. It's going to be next year in October, 27 to 30 October 2021. All of you are invited, and I think it will be a great opportunity to visit together the Grand Egyptian Museum. Let me send you this another message I just received from Gina, Professor Fred Gentili, will continue to teach his fellows from his bedside and continues to draw insight as a patient. July is reasonable as he is still recovering, having only been released from the hospital 4 days ago. Professor Gentili decided to start to restore his activities in one of our webinars, which is going to be held 2nd July 2020. Professor Fred Gentili, you are always great, and I'm happy that this webinar is dedicated to Professor Fred Gentili. Thank you very much.
Thank you, Professor Nasser, joining with us, your vast experience in this field. Thank you very much. And I think we have one last presentation from Professor Andre Greutenhuis. Hello.
Hi, Sean. Good.
Hi, Andre.
Hi.
And after this, I think we have some questions in the from the audience, and then we go into discussion. So please, Andre, present your endoscopic experience in the management of third ventricular tumors.
I try to switch off the air conditioning because that makes such noise. We have over 30 degrees Celsius here, so that's
same in Germany.
For us here, that's unusual temperatures. Humidity, but nevertheless, so I started sharing my screen and let me see where I am. Yes, I think this one is active, and I started up. Yeah, you can see it. Yeah, it is. I think now the attendees already know that we more or less dedicate this webinar to our dear friend Fred Gentili. I spoke to him yesterday, and he's recovering. He is at home, and I'm sure he will continue to teach, and that is great. I offered this lecture to Nasser when he asked me, would you participate? And I said, okay, let me discuss on the role of endoscopy in the surgical management of lesions in the third ventricle. That's a little bit, let's say, advanced. This is not the standard thing that we do. This is not a daily surgical procedure for us, not even weekly. You have already seen this beautiful with Dr. Koryashilev, how far it can go and how advanced it can be. I will try to take a practical approach to this. So what I will very quickly move through is the endoscopic anatomy of the third ventricle and point to a few typical things here. The type of lesions that you should expect there. And then, of course, the endoscopic approach to that area, give you a few examples. And at the end, of course, I'm open to questions. If you look to the anatomy, the anterior middle portion of the third ventricle is visible when we use the ETV approach. That means the standard borehole that we make there. That will offer us a view of the anterior part. What you see here in these images are cadaver and not patients. And that means it is more or less a normal third ventricle. In patients, especially with hydrocephalus, we see a widened third ventricle because normally it is slit-like, it is small. You have to rinse to get it wider. And then the floor is already wider. But that's the anterior middle part. Typically, you probably are now all aware of the landmarks that you will see by just looking with the endoscope at the foramen. So the tip of your endoscope, which is more or less the keyhole, you look to the depth, you look to the floor. So in the very upper part, you see the chiasm. Above that is actually the lamina terminalis and the anterior commissure, but that's not a 0 degree. The infundibular recess and the infundibulum itself, typically this speckled red area, that you should not touch too much, because this is the beginning of the pituitary stalk. Then the tuberous cinereum, that would, in the case of hydrocephalus, is usually thinned out. And the mammillary bodies that are very clearly seen in older children and adults. And in infants, they are typically not so well seen, but you can recognize them based on the vascularization. Has all been discussed. So if you take a 30 degree and look a little bit more upward, then you see indeed the lamina terminalis, and above that, the anterior commissure. This is something that you not normally will see, but if you want to go there, if that is your target, then you now have to realize that you need a 30 degree endoscope looking to the front. The posterior part is different, and that is what I will show later on. We have the suprapineal recess, habenular commissure, posterior commissure, and aqueduct. And yes, please think of the fact that the both sides of the third ventricle in the depths is hypothalamus. But this is not the image that you normally would see. And I will also, based on the time, try to quickly move through this and go there. Yes, I quickly go now here. Now you enter, this is foramen of Monroe, yeah, with the choreoplexus, and you enter it, you already see the massa intermedia here. You see there the mammillary bodies. So this is the third ventricle you will see when you just move into with an endoscope. The point that I want to make here, and let me again try to move this forward, but it is not so easy, is the fact that when this is massa intermedia, mammillary bodies, you see it here, very clear, tuberous cinereum, the infundibular recess. We go now, this is here the massa intermedia, and it's different in size. And now if you look above this, and now we have to realize one thing. The moment we go here and move our endoscope in this area, where is my screen? Here. What you now see, the lower image, so the lower part of your endoscopic image is actually anatomically the roof, so it's upward. Because you look from the front to the third ventricle, so the upper part, because of the endoscope, it's turned around. And that means here in the lower part, you see the roof of the third ventricle with the tila and the choreoplexus. And this, what often endoscopists in the beginning called the third ventricle diamond, which is this structure here at the habenular commissure. But you just have to remind yourself of this. This choreoplexus is the roof. So this is habenular commissure, pineal recess is there. This is suprapineal, habenular, pineal recess, posterior commissure, and there the aqueduct. Again, so that's pineal recess, there suprapineal, habenular, pineal, posterior commissure, aqueduct. This is just what I wanted to remind you all of, that, this is not repeating it again. This video was compiled by my previous fellow, Sharif Al-Khashin, who is now at the Tanta University in Egypt. And he made many of my videos, and I'm still grateful to him for all that work that he did. He was the best fellow I had. When we discuss lesions, usually space-occupying lesions in the third ventricle, typically we say, and it's such a small area, but we divide it into 5 areas: anterior, posterior, easy. In, at, or below the floor, at the foramen, typically foramen, think of colloid cysts, and then anything else that is not in this area, but filling up that third ventricle, so it's inside the cavity. that already makes a differential diagnosis. You see, there are quite some types of lesions that we have in the third ventricle. Typically, if you have purely anterior lesions, these are usually extensions coming from either pituitary or craniopharyngiomas or from the hypothalamus and chiasm, because I remind you, there was the chiasm, anterior commissure, lamina terminalis, that is involved into processes of that area. Posterior is tactile, pineal. And then inferior, so in the floor or at the floor, is hypothalamic hematomas. Suprasellar arachnoid cyst, typical thing for us to see. A lesion at the foramen is a colloid cyst, or could be a subependymal giant cell astrocytoma, which is typically associated with patients with tuberous sclerosis, and then the subependymomas. And in the cavity, that can be anything. In adults, it could be metastasis, lymphomas, typically pop up in the third ventricle, cavernomas, anything could be attached to the choroid plexus or not. So there is even a wider one. The next step to divide is, of course, the age of the patient. In pediatric patients, we have typically pilocytic astrocytomas, craniopharyngiomas, but also germinomas, Langerhans cells, histiocytosis. If you have an adult patient, think of metastasis, sarcoidosis, lymphomas, or even meningiomas filling it up. It's amazing to see that in this small anatomical area of the brain, deeply located, third ventricle, we have a vast variety of lesions. But you can bring it down in differential diagnosis if you take these classifications into aspect. Some examples here: colloid cyst, typical, and this is a subependymal giant cell astrocytoma. If you know that this patient is known with seizures and tuberous sclerosis, well, it is not so difficult to make already preoperatively the diagnosis. Here you see an astrocytoma. Pilocytic astrocytomas in this area are not always fully cystic as they are in the cerebellum. Polycystic astrocytomas in this area are often more solid. Nevertheless, they are still very well circumscribed and you can deal with them surgically. If they are not too large, you can do it even endoscopically, but I come to that. Here, a meningioma originating from the tila in the third ventricle and then filling up the whole space. And of course, in the posterior part, there was a teratoma. You have a lot. Not always think that cystic lesions in the third ventricle are colloid cysts, and just put in your endoscope there. If you very well look, you see it is away from the foramen of Monroe there and also here. So it is a little bit more posteriorly, and therefore it was wise to do in CTA because this case was a giant basilar artery aneurysm, and you don't want to go in with your endoscope unprepared and trying to think removing a colloid cyst while you deal with such a lesion. Other lesions, of course, cystics, the supracerebellar, they could be pilocytic astrocytomas like this one here with a mural nodule and then inside that, there are many, many lesions into it. Accentoastrocytoma, so it's a big differential diagnosis, but filling up the third ventricle. The same is accounting for the posterior third ventricular tumors. So the posterior part of the third ventricle, in the pineal region, it's nearly impossible to preoperatively clearly say what it is, because everything that you see on these scans, I mean, I didn't expect this one here on the lower end to be a pineocytoma, a fully benign lesion. Well, this was a teratoma, and this was a germinoma. This was a papillary tumor, grade 2-3. This was even a glioblastoma. They all look same. So for these lesions, we more or less still need surgical biopsies, and there endoscopy really comes into help. When we approach the third ventricle, I don't have to tell anybody of you as neurosurgeons that it is a deep-seated area. So any surgical approach means if you go there, only if you go to the lamina terminalis, you don't cross really brain tissue, but otherwise you have to pass through brain. And the shortest approach is not always the best approach to it. Because if you choose an approach also for the endoscope, it is, where is that lesion really located? Where is it originating? That is what we want to know. And when you have an endoscope available, you want to know if there is hydrocephalus, yes or no. If there is no hydrocephalus and a large lesion in the third ventricle, that precludes the effective use of an endoscope. An endoscope needs space in front of the lens to be effective. And you think already about the histopathology. Think of the vascularization. A very vascular lesion also precludes the use of an endoscope, because still hemostasis is a difficult issue in endoscopic procedures. And you always have to think in neurosurgery about hemispheric dominance. Having an endoscope and thinking of approaching the third ventricle, you know, these are transcortical approach. You go through the cortex. And most of the cases, to be very honest, in my whole experience now of the last 34 years, it is now not 33, 4 years, usually you think of biopsies, or maybe if you're lucky, you can debulk a tumor. And we have to realize that when with a pure endoscopic approach, so not an endoscope assisted approach, but purely endoscopically, you usually have only one working channel, or if you even have two working channels, it still is a kind of chopstick next to each other. So it is different from a microsurgical type of dissection. And you work on the fluid. And it is still the fluid, a little bit of blood, just a tiny little venous oozing already will disturb your image. While if you have an open approach and you remove the CSF out of the ventricle, you will not even be aware of that bleeding because it is so little. And that's the difference. So that really makes the technical issues here. So what are the cases that you could think of using an endoscope as the primary approach? For me, that means I prefer to have a hydrocephalus. I know my good friend Mark Sudain from New York, who has published a lot of cases of colloid cysts with absolutely normal or even small ventricles. He's a master. For me, that's difficult to do it technically. And to be very honest, the anterior location in the lateral, or here has in the third ventricle, it's wrongly written. So anterior location in the third ventricle is somewhat easier for us. It's more approachable. Think it is like an ETV approach. So if it is close to the foramen, subependymal giant cell astrocytoma, colloid cyst, is favorable. It's more easy to think of an endoscope. Size matters here indeed, a large size, and I write here 2 centimeters, that's not a strict line, but anything larger than that is already a cumbersome thing to do. And I prefer lesions that are not very vascular, because if they're not vascular, they're usually more soft lesions. Soft means it is partly suckable. We can more easily remove it. Or you can, nowadays we have even endoscopic CUSAs. If you think about these lesions that are intra and paraventricular, if you do that, at least the vast majority of the tumor should bulge into the ventricle so that you can approach it. I did a few cases in lateral ventricles, let's say, but also astrocytomas. You can't do it if the majority is outside of the ventricles. Then it is not useful to do. So some good examples you see here. This is still a good indication. Even larger ones here, subependymal giant astrocytoma. Even such a teratoma, which is turned out to be nearly avascular, could be removed. So these are cases that when you have experience in endoscopy, you can consider trying to remove them and deal with them endoscopically, purely endoscopically. These cases are wrong examples. These are simply not cases for endoscopy. These are neurosurgical cases, plexus papilloma, actually that turned out in this infant to be a carcinoma, and this big teratoma, that's standard open approach neurosurgery. This was from the article from Mark Sudane that I just mentioned on the resection of solid tumors. Of course, if they are small, we can think of that. And what he writes in that article, I like very much, because he say, if you think doing a endoscopic tumor resection, you have to do a disciplined patient selection, not just jump into it. And you need to have endoscopic experience. This is not your first, second, third, or fourth case you do with an endoscope. Can we do these cases? Yes, we can do them. And look at this, is a small one. This is a lesion, as you can see, that's originating, well, it was attached in an area close to the posterior commissure, a little bit tongue-like extension into the aqueduct. That size is amenable, and there is a hydrocephalus. 15-year-old girl with papilledema because of the hydrocephalus, negative tumor markers. So at least you do an ETV and a biopsy, but you can, in this size, try to attempt to remove it completely. You see this? There is quite a mesenteromedia. So higher approach, you had to go below it. That's the approach. If you plan such a lesion, navigation is a really, really great help. If you don't have it, it is calculating it from MRI scans in all three directions. What is important here is now we could really see on the T2 where the origin of the tumor was. And if you look very carefully, you see that the attachment is on the right wall of the third ventricle. So therefore, an approach from the left side was more comfortable. Coming from the right side would be difficult because then we see the left side better. So if you see this, that it is on this side is free, that side is attached to the wall, you need to have a contralateral approach. Typically, that's the keyhole approach, keyhole concept for endoscopy. That is that you often have to choose a contralateral approach. And there you see, indeed, it was a low-grade astrocytoma, a nice flow void through the fourth ventricle. And there you see this is, I think here, the people said, is that not a remnant on the posterior commissure? I tend to say that is because there was no attachment. That is a surgical effect of gliosis that we did there. So if you do tumor surgery endoscopically, use a solid lens scope. The fiber optic have the tendency of offering you not such a bright image. You should have image guidance because they are unusual locations. Try to avoid coagulation. It's not always possible, but don't coagulate too much when you do the biopsies, because then you deliver to your pathologist only coagulated tissue. And please, that's one of my strong advices, avoid endoscopic tourism. don't get overexcited of how beautiful this anatomy is. We all know it is beautiful, but that is not the goal of your surgery. So choose the best possible trajectory. And sometimes if you need to do an ETV and a tumor biopsy, you can't do it through one approach. What is dictating it? That's very simple. That's the size of the foramen of Monroe. If the size is very small, you can't do this from one approach. If those two things come closer together, then you can have, if this foramen is larger, then you can do it through one approach. But it's not always possible. In such a case, it was actually with the tumor case. This was a large tumor. You see here, very small massa intermedia. And you see the aqueduct. And there you see already that this was already done after the ETV. You see here, the ETV was already performed, pulsating floor. Oh, I showed still the ETV. Let's move on a little bit quicker. No, but that is, so you can still do that. But now go back a little bit. I told you not coagulating. If you see a vessel, of course you can coagulate. But now watch when you do a biopsy. Go with the biopsy and go deep into the tumor. You want to have deeper parts. And now you think I have a nice chunk of tissue. I can tell you, these are tiny things that you take out. Do you see the blurring of the image already? But take multiple. You will see not a lot this was a papillary tumor, grade 2. So you can take multiple biopsies and you should do that. In between, you rinse, you coagulate if you see some blood here, but take really effective samples because it is very cumbersome not having histology. You see it here? So you core out the tumor. You take out more of the tissue to have a biopsy. You saw this large tumor bulging completely into the fourth ventricle, so there was no way of removal. But in this case, through this larger foramen, we could do an ETV and check it later on that no blood is clotting it. That's important. And then at the end, you see this large foramen offered us the possibility to do so. Trajectory planning is important, and I just show you how we do it in an MRI scan. For example, in a colloid cyst, you have an axial plane and you have a sagittal plane. So laterally, you have the head of the caudate and you enter up in the genu of the internal capsule. So this is the border you want to avoid. To medial, you come into the column of the fornix. So if you draw these lines, you end up with the middle, which is the absolutely correct line to go to your target, avoiding the fornix, avoiding internal capsule and caudate nucleus. That's one plane, but we don't work in one plane. We also have the sagittal plane and of course a coronal plane, but that is easier to find. You find the upper part is the tila, but also again the column of the fornix. And then here, the floor of the anterior horn of the ventricle. So if you go back there and there, these are the outer limits, the limits of your approach. So then you find your right approach. And you can calculate that on an MRI scan. Just measure it. If you have navigation, of course, that's much easier to do. Endoscopic colloid cyst resection, we described that 10 years ago, also with Sharif, who did a lot of work for that. It's how you orient your scope. You coagulate the choroid plexus that is always attached to the cyst because it is pushed out of the third ventricle. And then sharp dissection of the capsula, coagulating vessels there. then you aspirate some part of the cyst. Never try to aspirate it completely, because if it is too sloppy, too soft, then dissection and mobilization becomes difficult. And at the end, then you can completely remove that capsula. And then finally, when you have taken it out completely, together with your endoscope, because it never fits through the working channel, you go back in, you do hemostasis. If there is a small clot, you suck it out. You always check the end-road. So again, this was one of the videos that Sharif made. Let me quickly put in. Typically, we have a lot of these cases. You see a choroid plexus that is pushed out of the third ventricle. This is choroid plexus coming out of the roof of the third ventricle. It has a little plexus cyst, but that is, we see that very often. Another case, plexus is attached to the cyst wall. And there you see the anterior septal vein, choroid plexus. The other vein deeper down was the thalamus striate. Or the left side, for example, sometimes you have to approach this to the left side. You coagulate the choroid plexus. And then you have to really, because this is here, this is what I show you here. That is the plexus of the lateral ventricle. But there you see, this is the area where we have to cut it. This is lateral ventricle. And the other one is from the roof of the ventricle that was pushed out by the cyst itself. So let me try to, because of the time, to push this a little bit quicker. The same, because this is all the same. You remove that choroid plexus. That's the first step you do. And then you take scissors and cut it out. So really cut that part of the choroid plexus and the lateral ventricle choroid plexus to detach it, because then you can open the cyst wall. It is freed from it. You open that cyst wall, it can be sticky, it is very difficult to tell. I mean, it's called colloid because it is a gluey-like substance, as you can see here. That's a typical gluey substance. An endoscopic approach, you hardly can avoid spilling some of these substance. Sometimes it is like this, it is nearly fluid, some greenish fluid here. Let's go somewhat further. And then you mobilize this cyst wall and you see that there is some spilling. It's unavoidable. You can then, because you have detached the choroid plexus, you can mobilize it into the foramen, because that plexus is already gone. You have done that. So you bring it more or less that you bulge it into the lateral ventricle, because then afterwards, move on a little bit further, you can detach it from the lateral ventricle part. The advantage is that at the end, you can take it out. This is an empty cyst, but you know this is a complete removal. And afterwards, as I said, you check again where you go. And then I prefer to have a 30-degree to look into the posterior part, because I had one case where the aqueduct was clotted by blood. And you see some clot is here attached in the roof. I told you that's the roof, the lower part of the image, but the aqueduct is open. That's fine. People say, do you do an ETV? No, because the floor is normal in those cases. That's no reason to do an ETV, because the obstruction was at the foramen of Monroe. So we don't do any things of that. I end with some tips and tricks. Don't start with such cases until you really feel comfortable with the endoscope, have done a lot of ETVs, have fenestrated cysts, and then you feel comfortable in handling that. Your whole team, your nurse, your scrub nurse, you can work together. I always tell them it is the same with the first dancing lessons. It's not looking very good, and you tip on each other's toes. After some time, it starts to look smooth and easy and feels more natural. If you have that natural feeling, you're ready to do that. Planning, as every neurosurgical procedure, is essential. So also for an endoscopic approach, not only open approach, do a proper planning. In such cases, certainly for third ventricle, if you have it, then you should use image guidance. And please, these are not quick procedures. If you deal with tumors, it takes time. That's important. Finally, you need a lot of rinsing because there is always some bleeding when you deal with tumors. And the most important part for me is ensure that the fluid that you rinse has a possibility to escape, because otherwise you blow up the third ventricle. I did this twice in my very first cases in the end of the 80s, so 35 years ago, and had one bradycardia and one cardiac arrest. So you learn from your mistakes. Make sure it gets out. It can be wet, but you ensure that the fluid gets out. And hemostasis is a difficult issue in endoscopic approach. Sometimes if you can clearly see the image, that you can coagulate. Some use a laser, but there is a nice instrument that you use. That's the same balloon that you use for the third ventriculostomy. You place the balloon, and when you inflate it, you give some pressure on the bleeding point. So if it starts to bleed, don't move your endoscope, because you know that you have seen that bleeding point, but you don't see it anymore because there is a readout of your image. But after rinsing, take time. And I know that 5 minutes of rinsing feels like an hour, but you have to do that. Take your calm. It will, but have a backup strategy. If you think I can't do this further on, either switch to open or place an EVD and think of a second possibility. And these are surgeries that I say, don't hurry, be patient. I think that's a general principle in neurosurgery. I hope there are any, and I'm of course happy to answer any questions, and I thank you all. And if you ever have the possibility, we come back to the oldest city of the Netherlands. It was founded by the Romans, by the Italians, more than 2,000 years ago. So be welcome.
Thank you, Andre. Great as usual. It's very important presentation. Actually, Andre is supporting all our educational activities in Egypt. He is always coming, educating our young neurosurgeons from Egypt and Africa, and contributing as faculty to all neuroendoscopy hands-on workshops. Hisham, you have questions?
Well, I look at the audience. I think there were some questions. I just
I don't see it actually in the Q&A.
Yeah, it's there were questions that I saw, but
I will still be around. So if there are other,
what is your opinion on select cases on one pre and post-op ETV ventriculogram? The question.
But that is probably, if it is after ETV, that is probably not a question to me, because I don't do programs.
I think theoretically that sounds a very attractive thing to do, to put in some contrast and see, but it hasn't been shown to be of great value, and there are no large studies confirming that it is of value. So putting someone through because the amount of contrast that you might get might not be sufficient enough to be seen adequately. So I think the MR sequences are better at showing the patency rather than doing a standard ventriculogram. I don't know whether anybody else has any other thoughts.
My good friend who died unfortunately too young, it was Dieter Helwig from Marburg with Bauer. In his very early experience, and he described that in a book, was doing in all those cases in ventriculogram, and then you could see that the contrast was going through the floor, but he stopped doing it because it never had any thing to do. It only proved that during that surgery, it was open and he could see if there was, of course, a stop, there was maybe a little aqueous membrane and then move on. But he said, I could always see that with the endoscope too, that there was a membrane. So he stopped doing it because it could even close after 2 days, after 2 weeks, after 2 months. It didn't do anything prospectively. So it didn't help. And I think the one case that made him stop was the patient that developed a seizure because of the contrast.
Absolutely, yeah.
And then he said,
it might show anatomical continuity, but functionally does not seem to. So there aren't any studies to support that. So I wouldn't do it.
Yeah. There's a question, can post-operative radiotherapy affect the success of the ETV function?
Yes, and what's been shown is that if patients who've had radiation, for some reason, the likelihood of success becomes reduced. And whether that's because there's an alteration in the absorptive mechanism of the CSF, or whether there is more scarring around the cisterns, both of those suggest that ETV is less like, and that's been borne out. So when one does get patients who've had radiation therapy, one of the things to inform them is that, yes, we will do the ETV, but it may not work, and we may still need to go ahead and put in a shunt.
Yes.
Any other thoughts? Walid, Andre, would you say anything different?
I agree that actually, I think also post-operative radiotherapy can. Because of radiotherapy, I still think of my very, 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 very first ETV patient who was irradiated in the 70s just without any biopsy for a pineal lesion tumor. That actually in the late 80s, when he had a shunt dysfunction, turned out to be a cavanoma on the MRI scan. And then he had 42 shunt revisions in 1 year. And he was more or less suicidal. And maybe we were also close to that because he was in and out of hospital constantly. And then because I did, but he had radiotherapy. And then because I had done it in the anatomical lab several times, I said to him, I have a new technique. Well, without it, I think within a split second, he agreed with that surgery, which considered in 1988 highly experimental. But he would have been agreed by shooting to the moon and back. That was also fine for him, if anything could bring him from. And then when I entered in, it looked actually like a cadaver dissection because the floor was whitish, was thick, was not thinned out. For me, that felt comfortable, but because it looked like the anatomy. Actually, oddly enough, it's still effective, it's still open after all those years. And that's incredible. But some other cases I did after radiotherapy failed miserably and quickly. But it's very odd to see. And I was stupid at that time. Sometimes you have to be lucky if you're stupid, because that man, I removed his dysfunctioning shunt. When he woke up in the recovery room, I said, it worked out fine. You are now cured from your hydrocephalus. And I sent him away. I had no Ommaya reservoir. I had no escape, anything. I did no lumbar punctures. He managed to do that. That's incredible, because that could also have ended catastrophically. Nowadays, I would consider his case as being a tough and difficult ETV case. But you simply never know. And therefore, sometimes you have to be lucky, and if you act stupid as a surgeon. So radiotherapy, just to say, I still do it. I will try it because there is a possibility. But the score, the success rate is lower indeed, unfortunately. It is.
Yes.
It is.
There is another question, how to maintain fluid outflow. Yeah, I think it's to you, Andre.
Yeah, I think, well, It depends a little bit on the way you do these techniques. In the beginning, I had an inlet where the fluid comes in, and I had an outlet also connected to a tube, and that tube was going to a basket where the fluid would, because otherwise our feet became wet. But then the difficulty was that during handling, it became a little kink into that outlet. And nowadays I just let it go out of the rinsing channel. So I open that channel, and therefore the pressure can never be higher than the heights of the endoscope. Well, in long procedures, this makes you. Sometimes my nurse tell me you better wear boots because it reminds me from the urology department, and it's very similar. It's very wet, but I'm happy that I know that the fluid always gets out, because it was more clean with having two nice tubes, but these tubes can kink. And while you are focusing on your image, you simply don't see it. You hope that your assistant or your nurse will notice, but they sometimes don't. So I now screw it off. And then you certainly know that it always gets out. And sometimes in tumor surgery, you have to rinse a lot. And with a lot, I mean, in that ependymoma that I showed, which was a small one, the total amount of fluid that was rinsed during the whole procedure, that took only about 1 hour and 10 minutes, was 3.5 liters of rinsing fluid, because it was constantly rinsing. And that's an amount. That's an amount.
Thank you, Andrea. I think, Hisham, we have other questions, but it's time to move to the next session, which is about skull-based endoscopic surgery. And to our next speaker, we'll have open discussion again after the end of the webinar or the end of the next session. Now we introduce Professor Walid Azab. He's going to speak about endoscopic endonasal surgery for uncommon cellular and paracellular lesions.
I will answer the other questions written.
Yes, we have actually the discussion is very interesting, Andrea, and we will yes, but it's very interesting really, and we will have another discussion soon after we finish the speakers.
Can you hear me well?
Yes, very good.
Good afternoon, everybody. Mr. Chairman, dear colleagues, ladies and gentlemen, it's a great pleasure to be here. And I would like first to thank Professor Nasser El-Ghandour for this kind invitation. I'm really thrilled to be with this elite of colleagues and our attendees. My presentation today will be on the endoscopic endonasal surgery for uncommon cellular and paracellular lesions. Apart from the common pathological entities encountered in this area, many other less frequent pathologies are seen in this region. And as a matter of fact, so many trials of classifying these lesions uncommon and rare pathologies, as well as their endoscopic endonasal surgical management. The first case is a giant cell tumor of the clivus. This pathology is very rare, actually, and about 15 cases have been reported in the literature. Boy who presented with recurrent headaches, and at the time of presentation he was having an abducens palsy on the right side. The preoperative imaging revealed this bony expansile tumor that was centered on the region of the clivus and the sphenoid bone. Preoperative MRI is shown here at the lower right corner, and it was iso-intense to the brain parenchyma, but with some punctate areas, and it avidly enhanced after endoscopic, after the contrast enhancement, something that is reminiscent of chondrosarcomas. In the T2 imaging, the lesion was mainly hypo-intense with some areas that are hyper-intense, just here. There. The lesion was approached and excited. See here after the central debulking, the tumor was noted to be having a very clear plane of cleavage from the surrounding dura. This is developed with the dissector here. And bipolar coagulation was used to control the bleeding. The tumor was moderately to highly vascular in some of its areas. Anyhow, further tumor debulking is undertaken. Piecemeal resection with a large rongeur. The dura here is the dura of the clival recess, and the cut section of the tumor, as you can see here, it looks mainly yellowish and very hard. So a large scissors was used to cut through the tumor, as CUSA wouldn't work at all in this. Further development of the plane, and more tumor is being exposed and removed. The tumor-involved bone was also removed from the clival recess. As you can see here, this is bone with tumor involvement. This is the dura of the sella. And then the parts in the vicinity of the clival carotid are resected currently. More tumor pits are taken out, and even a kerosene part for some involved bone. A dural defect is seen here with some CSF. It was not problematic later on at all, and the remainder of the tumor is removed. On the left side, you can see the post-operative MRIs. Almost a near total excision could be achieved, and the patient was kept on denosumab, which is recently approved by the FDA for treating these tumors. It was precluded from giving him radiation because of his young age and hormonal issues. His abducens palsy improved completely. And let me share with you some of the features of this tumor on the histopathology. It was mainly composed of giant multinucleated osteoclast cells that are growing in sheets and are intermingled with mononuclear cells in a rich vascular background. There was no evidence of mitosis or necrosis in that patient. He is doing very well. The next case is a renal cell carcinoma metastasis to the clivus, and this is actually one of the rarest locations for this tumor to metastasize, and about 9 cases have been reported in the literature so far, as per one review of the literature by Zhang and colleagues done in 2018. So this patient was a 54-year-old, absolutely previously healthy man who presented with abducens palsy on the left. His MRI revealed this very large tumor that involved the whole clivus, and it relatively respected the borders of the sella. And what was very notable on this tumor is the vascular voids that can be more clearly seen on the T2 images. Anyhow, this is the procedure, and during the endoscopic endonasal excision, I will just share some of these. So the tumor was not so hard, and it was not so difficult to remove, but the real difficulty was its very, very high vascularity. This tumor was bleeding like hell, and we lost a lot of blood during the surgery, as you can glimpse from this video. It never stopped until it was completely removed. And here is the view of the dura of the clival recess and the final hemostasis. The images are seen on the post-operative MRIs are seen on the left. He did very well, and his neurological deficit was also reversed in about 1 week or so, and he was referred to the oncology colleagues for further management. The next case is a case of a giant isolated sphenoid fungal mucocele. This is actually rare because isolated sphenoid mucoceles represent about of the etiology adds further to the rarity of the lesion. Anyway, that patient was a 68-year-old lady who presented with intermittent ptosis for about 1 year and was treated by the colleagues of neurology as a case of myasthenia gravis. However, at the time of presentation, she was having severe headache and left oculomotor palsy with complete ptosis and 4 millimeter dilated non-reacting pupil. Her visual acuity was severely impaired, especially on the left side, and the visual field index was 16% on the right and 1% on the left. This is her visual field exam, and preoperative MRIs are shown here. The lesion was expanding the sphenoid sinus and was displaying an intermediate signal intensity, and also on the T2 it was completely hyper intense except for that small nodule. Here is a video of the coronal T2 MRI revealing the extent of the lesion and its compression in the nasal structures and the orbits. Also, it abated the cavernous sinuses and the pituitary gland. Volumetric analysis revealed a size of 34.4 cubic centimeters. So, and here is the preoperative CT of the paranasal sinuses. It can be compared to the anatomical pictures here from the collection, and these are intraoperative images. You open the sphenoid sinus and the cyst wall into the nasal cavity, and here are the images on the right side. The cyst bulge here, and here is the view within the cavity after aspirating the content. That very thing that was seen histopathology to be a fungal ball, and using the angled scopes to inspect within the cavity of the sphenoid sinus revealed the anatomical features, as you can see here, the orbital apex here on the left and on the right. And at the conclusion of the procedure, this is how wide the opening is left behind, open into the nasal cavity, the anterior wall of the lesion. Post-operative MRIs with complete evacuation of the contents and decompression of the pituitary gland, the optic nerve on the right and the optic nerve on the left, and also here it can be precisely appreciated with the contrast images. Post-operative field examination, she had a dramatic improvement in her vision, and her oculomotor palsy completely resolved within 2 weeks. The next case is a recurrent case of a giant sphenoid mucocele. This patient was operated before in another institution, and these are, you can see here the adhesions from the previous surgery. Anyway, here is how the fluid appeared, and then the same idea of large opening of the mucocele into the nasal cavity, a view into the cavity from within the cavity after content aspiration. And here is the post-operative MRIs on the right lower corner. You can see how the cyst is open into the nasal cavity. Another similar case, pre-operative and post-operative MRIs and intraoperative images can be seen here. The next case is a pituitary xanthogranuloma. This patient was a 30-year-old lady who was treated under the care of the endocrinology colleagues. The upper panel MRI, she was treated with corticosteroids. However, a follow-up MRI that you can see in the lower panel here is revealing that the mass is getting larger and the infundibulum is getting thicker and more enhanced. So a surgical intervention was decided to know what is that exactly. Intraoperative serial images are seen here, and as you can see, the stunning xanthogranulomas or in xanthomatous hypophysitis. The posterior wall, and here is the picture at the end of the procedure, at the conclusion, after removing all the contents. Post-operative MRIs are seen here, and she was then referred to the endocrinology for further management. Another case is this lady who was 24-year-old, and she was having this lesion. She was actually sent because she was having just a marginal elevation on, in a case of a pituitary adenoma, and actually the histopathology revealed a pituitary sarcoidosis. The post-operative MRIs are seen here below with complete resection of the lesion. Another case which I will share with you today is a supracellular arachnoid cyst. Here is the preoperative MRI of this 52-year-old lady who presented with severe headache, and mainly her main concern was the visual impairment. She had a bitemporal hemianopia, and the MRI revealed this cellular and supracellular arachnoid cyst, which is quite rare pathology, because actually from the embryological and anatomical point of view, the cella is supposed to be devoid of arachnoid. And we proceeded with an endoscopic endonasal transcellular approach. The cellular face and floor were widely open, and whatever accessible parts of the membrane were excised. And you can see here in this post-operative MRI that the optic chiasm and the anterior cerebral complex have come down, and the supracellular cistern has came down. This was coinciding with her visual improvement, and she is doing very well currently. The next case I would like to show you is a pituitary apoplexy after a COVID-19 infection. We actually got this case report accepted for publication in Surgical Neurology International this month. That patient underwent surgery for a pituitary adenoma in another institution 10 years before. He was having a residual tumor, and he was having panhypopituitarism. Anyway, he presented with severe headache and visual disturbance with complete total ophthalmoplegia on one side and absence on the other side. And his MRI revealed that he is having a pituitary apoplexy. We operated on this. I will just show you the some of the features of the surgery here. It was a straightforward pituitary apoplexy case, very similar to any other pituitary apoplexy that we operate every day. I am just showing you the appearance of the tumor out of interest during that time, because everything related to COVID-19 is becoming attractive. And here is how the tumor resection proceeds as usual. And this is the highest part of the tumor, and the cistern and the tumor dome is retracted, removing the upper part of the capsule, and the cistern can be seen here. this is the fat that has been most likely used by the during the previous surgery. And one example of a pituitary tuberculous abscess, this lady was referred to us as that she is having a Rathke cyst. However, the findings were not consistent with this, and it was that material was caseated and it was completely resected, and she was continuing on her medical treatment. Another example is a tuberculous hypophysitis. Pre-operative MRIs and post-operative MRIs are shown here. And the last case that I will be sharing today is this germ cell tumor in a 13-year-old boy who presented with severe visual impairment, and the preoperative MRIs were showing this lesion with bifocal presentation that is very rare, very characteristic of a germ cell tumor, and his CSF markers were also negative. So the colleagues from the pediatric oncology needed a tissue biopsy, a definitive tissue biopsy before starting the chemotherapy. So we decided to go through the nose and do an endoscopic endonasal transcellular transtuberculum approach. Here is a video of the procedure. You can see here. This is the tumor after the exposure. And here is the optic chiasm. A biopsy was taken from inside the tumor, and it confirmed the nature of the pathology, the optic chiasm and the tumor bulge. And below you can see the post-treatment MRIs after he received adjuvant therapy, and he was following with the colleagues of pediatric oncology. And I would like to finally quote Oscar Wilde when he once said, "The true mystery of the world is the visible, not the invisible." Thank you very much.
Thank you, Walid, very much for this great talk and this group of very rare cases. It was a very good illustration about very rare cases. Almost
Thank you very much.
Each one of them is considered to be a case report. I think, Hisham, because we are late, it's better to move to our next speaker. Our next speaker is supposed to be Professor Fred Gentili. However, Professor Chandra Diopujari accepted to give his lecture by the same topic in order to maintain our program and not to make any changes. Diopujari, are you available?
I saw him. There. Maybe he should unmute.
Actually, he gave, I think he is trying to share his screen.
Okay. Seeing the presentation in the reverse mode.
Yes. Diopujari, would you unmic your microphone, please? Unmute your mic.
Can you see my screen?
Yes, perfect.
Yes. Just one moment. So basically, Fred Gentili was going to talk about open and endonasal endoscopic surgery for craniopharyngioma. And the contemporary data. I would like everybody to look at this Neurosurgery Atlas actually carries his guest lecture on this subject, conducted just a few months ago, and it is available on this link. I would like most of the young people to have a look at this to uh, understand his thoughts on this. I'm going to talk from our own experience and give you some of the ideas which we have learned over the years. So craniopharyngioma basically is a WHO grade 1 benign tumor, and we know that it is of two types for several years. Their molecular difference in their molecular biology and some therapeutic agents which are being used are probably going to make a difference in near future. But right now, our goals of treating these patients are mainly to improve vision, which is one of the major problems in patients presenting in the developing countries, to decrease the raised intracranial pressure because many patients still present with raised ICP, and cure from tumor, though it is a benign tumor and cure from tumor should be possible with surgery, remains a difficult goal because you want to preserve good functional status, as majority of these patients are children. And if you look at the 2007 analysis of Cochrane collaboration about interventions in craniopharyngioma, uh, 1016 papers were studied, and it was seen that almost 44 patients, 44% people felt that it is likely to be beneficial. 7% people felt that it is likely to be harmful. 49% that it did not support either benefit or harm. And almost 96% people said that there is should be further research. And there has been considerable interest in this, and more papers are coming out not only about the approach of the tumor, which is the subject of this particular talk, but also about overall management of this tumor. If you look at the surgical approaches historically, first successful surgical resection of craniopharyngioma was probably performed by Halsted by a transsphenoidal route. And later, of course, the Cushing and the whole group, and even Donald Matson, who reported first large series of craniopharyngioma, talked about craniotomy. Uh, Transsphenoidal approach went into not went into oblivion, but was performed by a very few people. And one of the main reasons where surgery became a little unfavorable is because of the evidence which people found that aggressive surgery was probably not such a great idea. And therefore, choice of treatment today is surgical excision, either gross total resection, subtotal resection, or maybe just decompression, plus minus radiotherapy or radiosurgery, and in selected cases, intracystic therapy alone. This is predominantly dependent on what is the clinical presentation. The neuroendocrine disturbances, neuro-ophthalmological deficits, raised intracranial pressure, and very rarely you get motor deficits or psychological symptoms. And though it is not reported very commonly, there are many patients who come with rapid visual deterioration or raised ICP requiring early intervention. The other thing on which some of the approaches are dependent upon is the morphology of the lesion. Is it predominantly cystic, predominantly calcified, or predominantly mixed? And it is also dictated in many cases by the direction of the tumor growth and the familiarity of the surgeon with a particular surgical approach. And though many people feel that the choice of surgical approach used has a very strong influence on the outcome, and this is particularly true probably for retrochiasmal tumors. So if you look at the overall picture of how surgically the craniopharyngiomas are generally approached today, the salar tumors are approached through the transnasal route, which was acceptable even earlier, though it was mainly a microscopic approach, but it has predominantly become endoscopic approach today. The intraventricular, or the so-called type 4 tumors, are approached by a transcranial intraventricular approach. Again, earlier they were mainly approached by microscopic approach, and today they are approached by endoscopic approach. And the suprasellar tumors probably require a greater degree of individualization. Just go through a quick recap of some of our cases. So this is one of the cases which was in fact our first case where we did endonasal endoscopic surgery for a craniopharyngioma. And I think this is an ideal patient. This is an adult, and he patient has a predominant cystic component. You can see that the diaphragm is raised up and it is a predominantly infradiaphragmatic tumor, and he already had hypopituitarism. And this patient, another patient, 14-year-old girl who presented with this tumor, again you can see the dome of the diaphragm stretched upwards, and this was predominantly a cystic lesion. And we have approached by a binostril approach here. Um, and here, what is of importance is to see that once you have opened the, this is extended approach, the intercavernous sinus being uh, divided to get into the enlarge the opening, and now you can see the whole tumor is coming out. And in this particular patient, we actually had the diaphragm completely intact, and you will find that there was no CSF leak at the end of the procedure. So these are not very common, and we have been able to dissect out the tumor capsule, and you will be able to see the uh, pituitary, which is plastered against the clivus and the stalk. And that's where it is coming out from the stalk. And these are the post-operative pictures. And this patient had mild hypopituitarism that has remained the same. There has been no diabetes insipidus, and she has been doing fairly okay. Another advantage which endoscopy and of course the neuronavigation has given us is that in a patient where there is no well-defined sphenoid sinus, you can still go ahead like we did in this 80-year-old, where you find that the whole sphenoid sinus is not aerated. In spite of that, it has been possible to remove this tumor completely. For a purely intraventricular craniopharyngioma, which is the most rare, but this is one patient where we found a purely intraventricular tumor, and we went actually through the foramen of Monro, which was dilated, and we could excise this tumor completely by this approach, as you will be able to see, and could dissect it out of the third ventricular floor. Some patients where predominantly they are cystic, we have been able to do it with the endoscopic approach, and this is another patient where we have been able to remove it completely. So let's talk about the suprasellar craniophryngiomas. When they are prechiasmal, which was the original kind of classification which was done when we were doing transcranial surgery, uh, the frontal approach or pterional approach is usually recommended, and it is probably gives a very good result. While in retrochiasmal tumors, you have to either use a lamina terminalis or Almufti is used Petrosal approach. And in these patients, there has been greater morbidity and mortality reported by most of the groups. And therefore, I think this is particular kind of tumor where endonasal endoscopic approach seems to probably fare better in the hands of many of the groups which are practicing this kind of approach. For further ease of understanding, this has been further subdivided into pre-infundibular, infundibular, and retroinfundibular by Kasam and his group. And this is also an important kind of classification because you know that you are more likely to get a good excision in pre-infundibular. You are likely to get a good excision in transinfundibular, but at the sacrifice of the pituitary stalk, while in retroinfundibular, you have to probably do a pituitary transposition, and therefore chances of hypopituitarism, if it has not occurred already, are very, very high. So this is a pre-infundibular patient. You can see that the pituitary is flattened at the clivus, and I wouldn't take you through the video. I think Dr. Luca is also going to show us you some, and this girl has done well. We have been able to remove this tumor by this approach. This is another patient who had a transinfundibular, and again, I think I will not take you through the whole thing, but you can see that we were able to preserve the stalk and left a little bit of tumor on the stalk here, and she's grown up well. And this is a patient who had a predominantly retroinfundibular tumor, which again has been possible to remove this after drilling the posterior clinoid, and we could achieve a complete excision in this patient. Recurrent tumors, I think this one patient, adult patient who presented with a tumor, had a transcranial surgery and then disappeared for almost 8 or 10 years. And then she came back with a cystic recurrence. And it has been possible in this patient because of the lie of the tumor. We decided to go, and a good well aerated sella, we decided to go endonasal. And you can see that even in a recurrent patient, after you have removed the cyst and the solid tumor is being taken out, and it has been possible in spite of that to preserve our stock, as you can see here. And it has been possible to get a good result, and no further treatment was required, and this lady did not suffer any diabetes insipidus. This is the stock, and you can see the uh, hole inside of the third ventricle, and this is a post-operative scan. There are certain other ways in which endoscopic surgery can help us, and we have used it for various reasons. But I think for the purpose of today's talk, it is mainly endonasal endoscopic surgery that we are discussing. Many a times we say that if the tumor has gone into the lateral corridor, it may not be possible. But this is one patient where there was a reasonably good corridor here. And you can see that the tumor is going towards the sylvian fissure. You can see this area of the tumor. But as there was a wide isthmus and a good corridor near the carotid, we thought we could probably try this. And I will just take you through this quickly. The stock has been preserved, and then we are going into the sylvian fissure here by angling our approach, and you will be able to see that we have been able to get into the sylvian fissure area once that part of the capsule has been taken out, and you can see the middle cerebral coming out from here. This is the post-operative picture in that patient. So basically, when there has been some institutional studies, this is children as well as adults, and they have found that surgical outcomes were similar via craniotomy, as well as except for probably more CSF leaks in transsphenoidal approach endoscopic, while more neurological injuries in the craniotomy cohort. And this is a meta-analysis of over 2,300 patients of transcranial and about 700 patients of endonasal. And they have again shown no significant difference in hypopituitarism, same proportion of transient and permanent diabetes insipidus, and similar recurrence rate. Similar papers have been published even in children by Dr. Capabianca's group, Dr. Locatelli's group. I think uh, you will probably hear about it later, Dr. Schwartz's group. And I will just talk about a small variation which we have adopted, that if the tumors are very large, predominantly cystic, associated with hydrocephalus, and patient requires immediate surgery, like this patient, what we try to do is we first go transventricular, and we would decompress this cyst. And once we have done that, by the time the patient is worked up, we look at the possibility of doing endonasal or transcranial. And then this patient was good for transcranial endonasal surgery. And I would like to tell you that one of the best advantages once you have decompressed the cyst earlier is that we were able to dissect this cyst out much easier. As you will be able to see that you do not have to actually put a sharp instrument between this and the surroundings. The cyst comes out very nicely, peels off nicely, and we have been able to achieve a complete excision. This patient, of course, had transient diabetes insipidus, but no other disturbance. And this is the catheter, which was, and you can see here on this side, the stock is plastered onto this wall. This is the post-operative picture, shows a reasonably good removal. In such patients, we do not do upfront radiation. We usually wait to see if there is any evidence of recurrence. This patient will get a radiation, and we've written about this earlier. When it is not possible to remove these tumors completely, like in this particular patient, we had to leave some tumor behind as we could not, in spite of second surgery by transsphenoidal approach. Then we subjected this patient to proton beam therapy. And in about 11 months time, this is a scan done, which shows that there is no residual tumor. Again, you see that the patient does not have his diabetes insipidus cleared up in about 6 months. So one of the big advantages we have found is that the morbid obesity and diabetes insipidus permanent basis has been reduced considerably. So when do we do craniotomy for craniopharyngiomas? When there is a predominant paracellular tumor, when there is a heavy calcification or a vascular encasement, if there has been previous injury to any of the vascular structures, if there has been previous radiation. The only patient who has suffered some vascular injury in our cases is a patient who has had previous radiation, and while separating a calcified component, the patient had uh, bleeding from a major vessel. And I think it is equally efficacious for a suprasellar prechiasmal tumor, like especially if it is a pre-infundibular tumor, like the craniotomy approach. And this is one patient which is predominantly, you can see that there is a tumor going into the temporal fossa. There is a tumor going on the opposite side as well. And we treated this patient by a craniotomy approach and been able to get a good excision. This is again endoscopy assisted. Another patient where we could not separately see the chiasm from the tumor, and we thought there was a large calcified portion. Here again, we resorted to craniotomy in this patient, and you will be able to see that the tumor had actually bisected the optic nerve, and it was possible after draining the cyst and removing this calcified chunk to get the tumor out almost completely by this method. And then we confirm that we have been able to get a complete excision here. And this is the post-operative scan. If the tumor is densely calcified, this lady presented with visual problems. And because of dense calcification, I thought I would not be able to dissect it out properly. And therefore, I went transcranial and removed this tumor completely, as you will be able to see on this post-operative scan. And this is a young girl where I chose not to go transsphenoidal because there was already a vascular injury during the previous craniotomy in this recurrent tumor. So we've actually got about 41 patients treated by endoscopic transsphenoidal approach, 25 patients by a combined endoscopic approach, transventricular and transsphenoidal, and by craniotomy, we've treated about 38 by terional and 8 by interhemispheric approach. This is our collective experience. Just to end with, I'll just show one case that there may be a role for both kinds of approaches. This is a 11-year-old boy who presented with this kind of a tumor. You can see tumor going into the anterior cranial fossa and both the sides. And we therefore decided to treat this tumor by a craniotomy approach, and we managed to decompress quite a lot of this tumor. And following this surgery, we found that the infradiaphragmatic portion of the tumor was not possible for us to remove. And at this stage, as the stalk was still intact and the boy was hormonally intact, we were wondering if we should give radiation or surgery. And the patient's family referred to go for surgery. So at this stage, we went endonasal surgery, and we have been able to remove this tumor completely, just like an diaphragmatic tumor. And you can see this patient's post-operative scan where it has been possible to remove this tumor completely. It seems that endocrinologically, there is probably less hypothalamic and hypopituitarism, hypothalamic disturbance or hypopituitarism after the endonasal endoscopic surgery. And these are some of our patients. So I think it is not open versus endoscopic surgery. It is probably use of both in a properly selected patients. And I think individualization is probably the key of management for craniopharyngioma. Thank you.
Thank you very much, New Pujari, for this great talk. And thank you one more time for placing Fred Gentili. Because we are late, I think, Hisham, we proceed to our next speaker, and then we make discussion at the end of the webinar.
Luca from Italy is presenting the endoscopic management of pediatric craniopharyngioma.
Thank you, and I'm very happy to be here. I thank the organizer for giving me the opportunity to be part of such an outstanding meeting. And me too, I'm waiting for Fred Gentili to come back among us. I'm proud to say that he was born in the same region of Italy where I was born. As mentioned by Shekhar Deopujari, the craniopharyngioma was defined since Harvey Cushing as a super tumor, the most forbidding or the most baffling problem. And I believe that his conclusion is really important to have a personalized, targeted type of surgical treatment. Unfortunately, I'm not able to put the presentation in the full screen. So I hope we don't miss my movies. So why the craniopharyngioma is so dangerous, I would say, in children. I will share some of the contents of my presentation with the presentation of Deopujari, if I will focus on my expertise, that is children. Why? Because, first of all, because it's a huge tumor often, sometimes a giant or a monstrous tumor, and especially because it can be associated with hydrocephalus and with frequent calcification. And the adamantinous variant is often without a clear cleavage plane with the hypothalamus. So all these problems make this kind of tumor really a forbidding problem. And we know that there is an increasing interest, of course, still I would say an increasing interest in endoscopic endonasal surgery. As you can see, the large amount of papers that have been published so far, and we know that there are about 2,000 papers about endoscopic endonasal and scalp-based surgery, but only 200 papers, 200 articles concerning children, even though about 1/3 of these papers have been published in the last 5 years. And we know that when dealing with children, the number of cases composing the series is not so high, because of course craniopharyngioma and cellular lesions in general in children are not so common compared with adults, but the interest, of course, is still important. What is the main advantage of endoscopic transsphenoidal surgery, not only in children, of course, but also in adults? Of course, the reduced morbidity due to the absence of vein retraction, other than, of course, the minimally invasive approach and aesthetical impact. But in children, it's very important, really key point to spare not only the brain, but also the growth of the midface and the nose. So this is another important advantage. The limitation in children may be the dimension of the nostrils and the nasal fossa, the possibility to get an adequate hemostasis, and the lack of a dedicated instrumentarium. But in my opinion, the most important one is the lateral extension of the tumor, but not because of a technical problem, because at the beginning of this session, Professor Delitala and Professor Gorelishev showed us how to overcome this kind of limit, but because of the need to destroy a part of the bone of a growing subject, like children, of course, with possible consequences. This is just a few slides on our series, just to understand what is our way to deal with this problem. I present 24 patients treated between 28 and 2018, just to have a minimum follow-up of 3 years. Nothing special about the endoscope, the instrumentarium. We use the two nostrils, four hands technique. The children in age 11 years were mainly affected by endocrine deficits, so 60% of the cases, other than raised intracranial pressure and neurological and visual deficits. It is important to note that a significant amount of them had severe preoperative hormonal imbalance. And we are quite proud to say that we have the same rate of gross total resection of experienced neurosurgeons like Eddie Lowe's, with a good amount also of subtotal resection following endoscopic transsphenoidal surgery. All the cases, of course, were adamantinous craniopharyngioma because we didn't include Rathke's cleft cyst. What about the complication? 2 cases of neurological transient deficits and 3 cases of CSF leakage. This is the most common complication after transsphenoidal surgery. And in 1 case, we were aware that the reconstruction intraoperatively of the cell was not enough, so we placed an external lumbar drainage. In the other 2 cases, we went back with a new reconstruction after the CSF leakage. This is the last slide about the series. And it is about the follow-up, 6.2 years. 17 cases are or disease-free, 14 or with a stable residual tumor. We had 3 recurrences, all managed by a new endoscopic transsphenoidal surgery and 4 progressing tumors. In 1 case, microsurgery. Only in 3 cases, we went ahead with radiation. More than the early outcome, which reflects, of course, the endocrinological assessment, it is important to note that the craniopharyngioma surgery has still some amount of morbidity. 77% of the patients require an endocrinological support. Of course, 60% of them already had a preoperative deficit. The same is for the visual deficits, 30%. The neurological deficit accounts for 10% of the cases. In spite of that, all but 2 cases that are 2 patients with significant visual deficits, all the patients are independent or attend normal school. So what are my considerations about this type of problem? First of all, as mentioned by Shekhar, we have to pay attention to the type of the lesion, to the location of the lesion, and I would say also to the age of the patients. 2 children treated successfully, as you can see, with 2 different types of lesions, but at 2 different ages. And we know that a 5-year-old boy, for example, still has to grow, still has to get his sexual maturation and so on. It's really different from a 13-year-old boy. So in this case, we can be more aggressive than in a case of a 5-year-old boy. The second problem is the location. Unfortunately, we had only 7 cellular craniopharyngioma. So when dealing with purely cellular tumor, things are quite easy. Of course, as you can see, we had 2 CSF leakage in this case because both of the patients were previously operated through a transcranial microsurgical route. But of course, I would say that the surgery is quite comfortable with a small kind of risk, and there is no doubt about the indication. Different is the problem of the supracellular tumor and the supradiaphragmatic tumor. Sometimes, like this case, there is already a multimodal treatment enacted that was done through an interferon, intracystic injection of interferon. So in this case, I believe that in any case, the transsphenoidal surgery is the best route. As showed by Shekhar, sometimes, of course, there is still a catheter that was placed for the treatment, as you can see the third ventricle from below. It is important in this case also to have a CT scan for identifying possible calcification. And it was important in children, the nasoseptal flap, to reduce as much as possible the risk of CSF leakage. So what about the transcranial route? Should be it abandoned? Not, of course, because it is still a really important way, especially for the pediatric neurosurgeon, especially in cases like this one, supradiaphragmatic, and with strong calcification. So we cannot abandon this kind of technique. And it is important for the correct management of this kind of lesion. Of course, the dissection is not so easy. The space should be gained step by step, but with a correct maneuver, sometimes we are able also to spare the pituitary stalk. Of course, in case of huge tumors like this one, the most important aspect is to decompress the child as much as possible and as soon as possible, and to go ahead with a multimodal treatment, but I'm going to say some more about that. Sorry for that, because once again, I have a problem with this. But this was just to show you that sometimes we still have concern on what kind of approach to use for pediatric craniopharyngiomas. I agree with my friend Jeffrey Wisoff, who was the author of this paper, that we can use different approaches for different type of lesions and different types of patients. Of course, I disagree on to use the transcranial approach for suprasellar tumors, because we demonstrated that we can use the transsphenoidal surgery in many, but not in all, suprasellar tumors. This other paper was just to show you that the CSF leakages was the most common complication with transsphenoidal surgery, much more than for the intracranial surgery, but intracranial surgery is burdened by a large number of other complications compared with transsphenoidal one. I don't know if some of you still use the sublabial approach. Of course, I believe that in children there is no more space for this kind of surgery that we use until 2005, before the introduction in our institution of the endoscopic transsphenoidal approach. We demonstrated in our series that there was a gain in terms of reduction of hospital stay, reduction of the routine access to the intensive care unit, the blood transfusion, and the need of the nasal packing. And for sure, there was also a significant reduction of the pain, the postoperative pain. This was largely demonstrated by our papers. So I believe that the sublabial incision is not more reliable tool to manage the craniopharyngioma in children. The poor mucosal trauma and the absence of late nasal and especially cartilaginal and mid-phase bone complication makes ideal to this kind of treatment for the craniopharyngioma. But of course, the treatment of this tumor may not be limited to the surgical management, or at least to the endoscopic approach. Why? Because craniopharyngioma is a benign tumor, of course, which is associated with a long survival of the patient. So we need a gross total removal, at least whenever possible. But of course, we have to pay attention to the quality of life of the patients. We have not only to be able to remove the tumor, but also to preserve the function of the patients. So gross total surgical conservative management, partial of total resection plus radiation has a higher risk of recurrence, but a lower risk of complication. So this is not, of course, true in any case. As you can see from the literature, the gross total resection of the tumor is possible not in all the patients. The rate of complication is high, but the risk of recurrence is not nil. On the other hand, also the conservative management has some risk of hypothalamic dysfunction, and in particular, the late risk in terms of cognitive delay and second tumor of the radiation are not trivial. Shaka has already mentioned this paper. Is a possible suggestion is to try to attempt gross total removal in the most favorable case, the grade 0 and 1, and to approach with a conservative management the grade 2, where the hypothalamus cannot be recognized. I will add, of course, the possibility to have multimodal management by using also the ventricular endoscopy that can be used to, for example, decompress the patient. And as you can see in this case, by a simple fenestration of the cyst. The fenestration of the cyst, of course, may allow to reduce acutely the rise of intracranial hypertension. And of course, can be used also to place a catheter to favor neoadjuvant treatments, for example. But ventricular endoscopy can be used also to manage the hydrocephalus. Like in this case, as you can see, the tumor causing a biventricular hydrocephalus, and of course, the endoscopy can be used for septostomy to treat the hydrocephalus. But the cyst fenestration can have also other goals that are very important that can be reached by a simple fenestration, or also, as I was mentioning, by placing an intracystic catheter. It can be done, of course, also through a purely navigation assisted procedure. And the rationale is not only to relieve from rising intracranial pressure, but also to decompress the nervous structures to favor the radiation treatment. This is really important because it allows to reduce as much as possible the irradiation field. And it should be considered that the adamantinous craniopharyngioma shows often a very large cyst, but the solid portion is reduced. To favor the intracystic chemotherapy, I'll show you something about that, and of course to wait for radical surgery. It was quite surprising for me to look at a couple of reviews of the literature showing such good results only for the simple fenestration. After a 7-year-long follow-up, about 70% of the patients, they were mainly adults, more than children, I will say, but they had their disease stopped just after the cyst fenestration. The complication may be, this is what we do as the intracystic treatment is called brain toxicity, but we use another chemotherapy that is the interferon alpha. This is the protocol. The interferon alpha is an antiviral protein that is able to shrink the cyst of the craniopharyngioma, as you can see in this case, just leaving only the small solid portion. This is another example. And it can be used also repeatedly, but this is not a definite treatment of the craniopharyngioma. This is just to gain time and to allow the patients to get their maturation. This is a busy table, but just to show that there are several experiences with the interferon alpha, sometimes with a subcutaneous injection that we don't use because of the risk of a grade 2 or 3 hematological toxicity. I just underlined three series. The first one is a Brazilian and Italian experience where we contributed with our patients. The second one is the multicentric international study where we contributed to, and this is our series. In any case, the craniopharyngioma was intracystic. We had in the first experience 78% response to the percent of response to interferon alpha. So only 22% of the patients had to be treated surgically with a complete, surgical operation. In the international experience, 25% had a complete response, 75% a partial response with 57% of the cases treated surgically. This is our experience. We carefully selected, of course, the patients, so we had such a good experience, but I want to remember once again that this is an experience which has a limited value in the time. The complication of the interferon alpha injection are usually poor. This is the technique we use. Catheter. This is a navigated procedure. With the laser, we fenestrate the cyst, then we put inside the catheter, and this is the postoperative result. This was our personal protocol. As the first line, we use, of course, surgery, endoscopic surgery for the skull base whenever possible. And for prevalently cystic tumor, of course, we use the interferon alpha, and then a surgery, of course. Only for recurrent tumor, we use a second line treatment, radiation. Of course, if we have radiation, even after, if we have recurrence, even after radiation, or in case of progression after interferon treatment, we use again surgery. So this is to say that surgery is the most important tool that we have to manage craniopharyngioma. This was our experience following the trend that we had also in the literature. Between 1980 and 2000, there was significant progress in the technology and in the technique of the neurosurgeon. So there was a possibility to increase as much as possible the resection of the tumor with a reduced operative mortality. So the surgery was favored against the conservative management. But starting from 2000, we had to pay attention to the quality of life of the patients. You can see this young girl is obese and is blind also. So this is not so a good result in spite of the complete removal of the craniopharyngioma. So we started to pay attention to the quality of life, and we promoted the conservative management. Now, what is our way? So we saw that there is a certain increased risk of recurrence that is not more acceptable with conservative management, and that we have some adverse events also after conservative management. So probably we are coming back to a more aggressive surgical behavior. So in conclusion, what about the limitation of the endoscopic surgery in children? As mentioned by Professor Diopujari, we didn't find no problem with the missed pneumatization of the sphenoidal sinus. We didn't have problem with hemostasis, problem with dedicated instruments, no anatomical problem. So in my opinion, the most important problem remain the craniopharyngioma. The two nostris forens techniques that we use is, in our opinion, advantageous in children, because we can use 2 or 3 instruments simultaneously. There is an active role of the assistant operator, and we have to check continuously with the synchronous movement of the endoscope and the operator, the bleeding, and also the hidden angles of the visual field. Of course, the operator and the assistant operator have to work with a good comfort between each other. And I believe that the most important aspect, especially where dealing with children, is the experience. As you can see, in the same period that we started doing the endoscopic surgery for the skull base, we collected only 84 cases. That is less than 5 cases per year. But we had about 800 cases of ventricular endoscopy. So it is important also the learning curve when using this kind of surgery in children. And I leave you once again with Cushing that say that the performance become progressively simplified by the combined suggestion and experience of many. That's why I'm so happy to share with my experience with you and to receive your experience today, and I hope it is the same also for the people attending this meeting. So I thank you again for the attention, and thanks Nasser and Mahmoud for the kind invitation.
Thank you very much, Professor Luca, for your yeah, very practical and presentation with a vast experience for your center. So because we're very advanced in the time, I present Professor Alvaro Cordoba from Uruguay to give his presentation.
Perfect. I will share my screen.
Yes. It's perfect.
Okay.
Mm.
Okay. Do you see well?
Yes.
Yeah. Perfect. Well, I will promise to be very short, very brief, because it's a very interesting case that is possible to think about the endoscopic approach of brainstem cavernoma. Professor Goresliev showed one interesting case, intraventricular cavernoma, and we saw one or two cases, but no more, with the resection through the use of the endoscope to try the resection like a tumor. But in this case, it's possible to use sometimes in the pure approach endoscopic in the brainstem, and sometimes possible to use also like the assisted procedure, endoscopic assisted procedure. This is our activity since a long time ago. We started a lot of places, but I remember very well in Europe, in Vienna, then in St. Louis University, and a lot of activities here in Uruguay and the Latin American group. We have this our disclosure. This is our experience. Since a long time ago, we tried to identify all of the patients that we did, but actually it's more than 1,500. But in this our series, only two cavernomas, one intraventricular and the other was in the brainstem. But this is a particular cavernoma. It's not the same for all of the cavernomas. Sometimes it's possible to use like an assisted procedure. This was the first procedure in Uruguay. It was very important for us. We started in endoscopy a long time ago with different kind of things. What was added to the neuroendoscopic procedure, like the EACP monitoring and so on, was very thin, the use of very thin endoscopes. And this is our first paper that was published in Naples. And that I meet all of my very good friends, like Professor Rothenhuis and Professor Bauer, and all of the German people that I learn a lot in endoscopy. And I never forgot all of the very important authors in anatomy, because I am neuroanatomist. It's a long time ago. But actually, they have a lot of technology, but in the past, what described a lot of very important anatomical structures that they are very important to recognize in endoscopy, mainly in neurosurgery. So it's very important to remember, for example, one very important book for Raymond Vieuxin, the Neurographia Universalis, since a long time ago, and using the fixation, but boiling water and oil. So actually, it's very important to describe all of the tracks in the MRI and so on, but what described for the first time a long time ago by Raymond Vieuxin. This is a very interesting case. It's a 57-year-old woman, but what treated actually was a long-term hydrocephalus. One start with she was a child, and actually last year we started with headaches, with vertical diplopia, dysarthria, and cognitive disturbances. It was very interesting, but a long time ago, when she was a child, was treated by a very well-known neurosurgeon from the pre-tomographic era, and was very interesting because very difficult procedure to start in 1972 with only this kind of images in the preoperative planning. You see, this is a nuclear medicine, this is a centrography that is very interesting to see what happened inside of the brain, but she was operated by this kind of images by this very famous neurosurgeon here in Uruguay without CT. We have not CT at this year, and you see only hydrocephalus. We see the frontal images and the sagittal plane. Only with this was operated, but the surgical procedure was enigmatic because we didn't we asked to the patient what happened, and probably was not treated, but the hydrocephalus, they didn't attempt perhaps to perform a shunt, perhaps function or nothing. The problem that's actually we start perhaps more than 30 years after this procedure with all of the symptoms. But actually, with the modern images in the modern area, you have this lesion near to the brainstem. This is a cavernoma in the variety of the cystic cavernoma near to the part of the posterior part and upper part of the brainstem near to the colliculus. So you see near to the aqueduct that is dilated, also the hydrocephalus, but this lesion appears like a huge cavernoma comprising the aqueduct, like a non-communicating hydrocephalus. And we tried to think what happened if it's possible to approach for the first attempt to an ETV, and then to try, if it's possible, through the aqueduct that was dilated, try to resect this kind of, only this kind of cavernoma. This is a cystic cavernoma with fluid inside, like a chronic subdural hematoma. And this is one of the first types of cavernoma inside of the brainstems. So it was possible to perform this, this procedure. And this is this was the patient last month. And it's very interesting to see what happened with some histological subtypes of cavernoma. This is the variety of the cystic form that normally is possible to see normally in females, in elderly patients. Normally the mechanism is the formation of a large cyst is something like happened with the chronic hematoma. That is a very rare type of the cavernoma, but it's possible also to drain all of the content inside of the lesion. And it's possible sometimes to resect all of the wall with the vascular structures. But it's very interesting what happened in the histologic examination. Normally the CCME2 gene is, or the malcavernin, is located at the 7p, normally in chromosome. And sometimes in the studies of Plummer and a lot of authors demonstrate that it's possible to see in the family type of cavernoma pathologies, normally more than 40%. So that suggests that cavernoma may arise perhaps surrounding neuronal area, and not only perhaps they are vinculated to the vascular structure. So it's possible to see around of the lesion of the cavernoma neurals and glial cells rather than in vascular endothelium. That is very interesting to see. This is the only type of cavernoma that is possible to approach, perhaps like a pure endoscopical approach. This is all of the varieties of the MRI. Normally, it's possible to see hypertense or hypotense in the or near to the core, with subacute or chronic hemorrhage. But the type 3, that is our type of our kind of type of cavernoma inside of the brainstem. So it's possible to approach like a common lesion with fluid inside, like a cystic lesion. It's possible to use endoscopy inside of the lesion. This is part of the bibliography. And to date, we saw only one case that was approached by Professor Gavin Schroeder inside of the ventricle near to the foramen of Monroe a long time ago. And it's very interesting, perhaps, to see what happened with other authors over the world. Thank you very much for your attention.
Thank you very much, Alvaro, for this great talk. Now I have the honor to introduce Professor Samer El-Baba. He's going to speak about endoscopic assisted microsurgical techniques for pediatric brain tumors.
Thank you, Professor El-Ghandour. A great honor and pleasure to join this amazing webinar. I learned so much from the speakers, as always, great teachers. If I may share my screen. Professor Cordova, can you stop sharing yours?
Yes, for sure.
Thank you, my friend.
No.
Is it projecting well?
Yes, perfect.
Okay, thank you, my friends and colleagues, and great honor to be with you here today. Thank you for the kind invitation. I will give a short talk on the use of endoscope-assisted microsurgical techniques and for use in pediatric and skull-based tumors, pediatric brain and skull-based tumors. The speakers already gave wonderful talks on craniopharyngiomas and ventricular tumors. Today, I will just focus on the endoscope-assisted microsurgical side. As we all know, whenever we want to do any neurosurgical intervention in the brain, it's always good to stop and think about what are we exactly doing today. Are we, what kind of gray matter or cortical matter we're going to go through? What are the white matter tracts we may be disrupting? As we all talk about the highly eloquent cortical entry points, for instance, the motor and sensory strips, the optic radiation, supramarginal gyrus. We always talk about eloquent white matter tracts as corticospinal tracts, the cortical optic radiations. But I had the pleasure and honor to work under Professor Yasugo when he used to be in Little Rock, and he always used to say the whole brain is eloquent. So all those white matter tracts and cortical gray matter entry points we talk about, yes, they are all eloquent, but we should always focus on the whole brain as eloquent. As Professor Grottenhaus showed us, whenever we deal with tumors in the ventricular system, there are different ways to get into the ventricular system. And depending on the pathology and the location and the type and the size and the ependymal attachments, we decide on which approach we use. Unfortunately, over the last 20 years, there has been significant bias and controversy between endoscopy and microsurgery. And I have been fortunate to work with colleagues and learn from them that the best way is to get the use of both technologies. And it doesn't matter if you use endoscope or microscope. What matters is that you achieve the goals of the surgery safely. And as late Professor Panetsky described endoscope-assisted microsurgery as a minimally invasive technique with maximally effective treatment. It's a good time to look to step back and talk to the residents and students about the main differences between endoscopy, endoscope controlled surgery, and endoscope assisted microsurgery. Endoscopy or endoscopic techniques, as many of the mentors showed us today, is when we use the working channel of the endoscope to achieve the work, similar for ETV or endoscopic tumor surgery. Endoscope controlled is similar to what Professor Azad showed us. And when we use the instruments in parallel to the endoscope. So we use the endoscope primarily for visualization. And endoscope assisted is when you are primarily performing the surgery with using microscope, but the endoscope is used during different portions of the surgery for better visualization of corners or to achieve maximal resections. Some cases I will share with you, only short cases. 9-year-old child with optic pathway glioma and complex hydrocephalus. You can see the cystic portion of the tumor is occluding the foramen row on the right side. The patient already has a shunt on the right side. Clearly, it's responding to chemotherapy. The patient has a good vision. So we all know that most of those tumors are treated with chemotherapy, but unfortunately they develop cystic components. And in this case, we elected for interhemispheric transcallosal approach to debulk the cystic portion of the tumor, but at the same time, more importantly, to communicate the ventricles. And this is the value of the endoscope. Now we can see the septum pellucidum communicating the right and the left side. Here's debulking of the tumor. And now we can cross to the other side, and now we can see there's excellent communication. Another child, this is a 4-year-old child with multiple cranial neuropathies who presented with this prepontine cystic mass. And we can see here the child already presented with multiple lower cranial neuropathies. We can see here on FLAIR images, prepontine cystic mass looks large. It's displacing the basilar artery and its perforators ventrally. When we look at T2 images, we can see the contents of this mass are very different from the CSF content. We can see severe displacement of the brainstem posteriorly. And interestingly, when we looked at the corticospinal tracts, we can see how actually they are displaced in a C-shaped appearance around the mass. And actually, the DTI tractography showed us that the fibers were displaced to one side than the other, and that helped me decide, coming in this case from the left side, mapping out the transverse and sigmoid sinuses and planning a retrosigmoid approach, but at the same time prepared to convert it to a far lateral approach if needed. Starting with the retrosigmoid approach, you can see here the mass in front of the brainstem, which is pushed posteriorly. Aspirating the cyst came back as a greenish fluid, suggestive of likely neuroenteric cyst. Now the next step is to work between the all the lower cranial nerves, arachnoidal windows, but most importantly in this case, we can see the basilar artery and one of its perforators are embedded in this cyst. So we know neuroenteric cyst, we have to achieve maximal safe resection of the cyst wall. We can see here, this is the basilar artery and this is one of the perforators, and now doing sharp micro dissection of the cyst wall and excising it and creating windows between all the perforators of the basilar on each side. After that's completed, all cranial nerves are preserved, the basilar perforators are preserved. Now it's time to bring the endoscope. And here we can see the endoscope retrosigmoid approach. You can see all the cranial nerves from the 4th down to the 12th nerve, and all the perforators of the basilar, the icas, the picas, and now we can see here the contralateral internal auditory meatus can be visualized here, and now we can confirm that there has been no residual mass. And when we look at the post-operative MRI, post-operative day 1, there's immediate return of the brainstem back to neutral position. You can see how the brainstem went from this shape to this shape just within 24 hours. And after 6 months, you can see the brainstem, which was only 4 millimeter thickness, back to neutral position and almost back to normal size. And the patient developed most of the neurological deficits. This patient developed obstructive hydrocephalus. I attempted an ETV. It only worked for a few weeks, and then I had to place a shunt. But you can see here in this case, the endoscopic assisted microsurgical technique was very helpful. How about for intraaxial lesions? This is a child, a 7-year-old child who presented with a classic left temporal seizure. So we can see here an enhancing mass in the posterior hippocampal gyrus. It's very posterior. You can see here on the sagittal image, it's just over the tentorium. So on neurologic examination, the patient was normal. Visual field testing was normal, and the neuropsychological testing was normal as well. So the question is, for this enhancing mass in the posterior hippocampal gyrus and the dominant hemisphere, this child is neurologically intact. It appears to be a ganglioglioma by definition. So as we know, gangliogliomas, the treatment of choice is gross total resection. I know some other programs may consider laser thermal ablation for this mass, but we elected for gross total resection. Attempting an anterior approach for mesial temporal lobectomy, in my opinion, this is a long reach. If we try transcortical, this can lead to interruption of the Myers loop and the optic radiation. So I elected for a supracerebellar transtentorial approach. You can see here also, very importantly, if we look at the T2 and FLAIR images, we can see there's clear edema around the mass in the perihippocampal gyrus. And in my opinion, this is a classic indication to achieve tumor resection rather than epilepsy surgery style of resection. There is no need to remove this gyrus surrounding the tumor. So removing the tumor alone will take care of this edema. So this was performed via supracerebellar transtentorial approach. This is an excellent approach for posterior parahippocampal gyral lesions. And this was described by Professor de Oliveira in Brazil, Professor Ture in Istanbul, excellent literature published by both groups in Istanbul and Sao Paulo, and showing a very beautiful approach. In this case, we do semi-sitting position, we do continuous electrocorticography to monitor for air embolism. During surgery, use a paramedian suboccipital approach just under the transverse sinus. I started the surgery with the microscope, and here you can see doing dural opening just under the transverse sinus, and the dura is lifted over the sinus. And very important to open the cisterna magna. This allows immediate release of the CSF and relaxation of this cerebellar hemisphere. The next step is to bring in the endoscope, and I like using the endoscope to perform the transtentorial opening. And the transtentorial opening is primarily performed endoscopically or endoscope control technique. The next step is to bring in the microscope and perform microsurgical resection of the very thin rim of the perihippocampal gyrus surrounding the mass. But the next step is to perform resection. You can see here calcifications, now performing using the aspirator for doing the transtentorial resection of this mass. Now, after that, we bring the endoscope, and the endoscope helped me identify that I left a big residual, actually lateral to the P2 segment of the posterior cerebral artery. And this is the view the microscope was never allowing me to see. Now I'm performing endoscope-controlled aspiration and resection of the residual portion lateral to the PCA. And now with the endoscope, you can see PCA is intact. This is the healthy parahepatic gyrus, and postoperative resection can be appreciated via transdental opening. And if we look on the postoperative MRI, you can see here is the tentorial opening, small opening tentorium, postoperative resection of the mass. But most importantly, if you can look with me here on the T2 images, you can see here that the edema and the parahippocampal gyrus disappeared, seizures disappeared, and the patient became seizure-free. How about in the pineal region? For instance, this is a 14-year-old child I was watching in my office for many years with a pineal cyst. And then suddenly the headaches got worse, the cyst got larger. And you can see here on T2 images, the contents of the cyst look highly proteinaceous, different from the CSF. Obviously, we can use an interhemispheric approach. We can do posterior interhemispheric transtentorial, or we can do supracerebellar infratentorial. As we gain experience in performing endoscope-assisted or endoscope-controlled supracerebellar approaches, then you'll feel slowly more comfortable with performing supracerebellar approaches to the pineal region, purely endoscope controlled. Like in this case, the microscope was not used. It was purely endoscope controlled. You can see here the incisura region. You can see here the right thalamus, left thalamus, the vein of Galen, and here you can see the right basal vein of Rosenthal, left basal vein of Rosenthal, and here is the mass. We start by blunt dissection, taking down the arachnodal adhesions, and now we're doing endoscope-controlled separation of the cyst or the mass from the right basal vein of Rosenthal. Again, here's the vein of Galen, and here's the right thalamus. The next step is to do bimanual, endoscope-controlled bimanual resection of the mass, separating it from the right thalamic wall. I'm always concerned about any attachment of the mass to the internal cerebral veins in the roof of the third ventricle. In my opinion, this should be done as the last part. Now, the last step is to do endoscope-controlled removal of the mass and separating it from the internal cerebral veins bilaterally. And now doing a final round of inspection, again, vein of Galen, bilateral basal veins of Rosenthal, and now we are looking at the choroid plexus and the roof of third ventricle, right thalamus, left thalamus, all clean from any residual. And here you can see a few months after the resection, the cerebellar hemisphere shows 0 signs of edema from retraction, and the mass was completely resected. And whenever we consider any endoscope controlled approaches, it's important to always think about the positioning of the patient. It's always important to use gravity safely in semi-sitting position. I found it to be very useful for those approaches. Again, this is a quick talk showing different endoscope-assisted approaches for pathologies. I'm going to skip the few cases I have about craniopharyngiomas, endoscope-assisted craniopharyngiomas, since my colleagues have done an excellent job identifying them. In conclusion, microsurgery versus endoscope-assisted surgery should not be looked at as a battle, should get the benefits of both. We should always think about the anatomical corridors we use and which cortical gray matter entry point we're going to use, and any surrounding or any white matter tracts we would be potentially injuring. At the end of the day, anatomical knowledge, using any technology you have in the operating room, and the surgeon's personal experience are altogether will achieve the best goals for patient selection and careful planning. Thank you.
Thank you very much, Professor Samer El-Baba, for this great talk. Now we open discussion, and we see if we have questions over the panel. I think we have few minutes to make a discussion. And I think we have over the panel, Hisham, I can see a question to Andre.
Andre, oh, yeah. Can you expect the content of the colitis from the MRI pre-op? So that's a question for you, Andre. You have to unmute yourself.
Sorry about that. That's one of the technical issues here. No, I think sometimes you can. Typically, what I look at, it's the T2 sequence. On the T2 sequence, when it is black, that points out that it is a much more, let's say, buttery consistence of the colloids. It's more stiff, so more difficult. You can't aspirate. If it is very bright on the T2, it's more like a fluid. So that's more easy to aspirate. And that's about it. So some people say actually that the black on the T2 is a contraindication to do it endoscopically, but I don't agree. For me, is but there was also the we have a thunderstorm going on now, and well, it was very hot, and then usually at the end of a hot day there will be a thunderstorm. No, but T2, if it is dark and stiff, that's even a little bit easier to do it endoscopically, because as I told in the lecture, it's an advantage to not fully empty the cyst, because if you have an empty I hear a lot of noise, and I don't know if it's me, but
the thunderstorm.
No, I don't think so.
Yeah.
But I hear a lot of noise around it. If you have a very thin cyst that is fully empty, you can't distinguish it anymore from the tila and from the arachnoid. So you have no clue. Am I trying to remove arachnoid? Is this still cyst wall? So distinguishing it. I leave always a little bit inside the cyst, because that allows the dissection. And if this is the dark on the T2, so a little bit more buttery, it's even heavier. And especially if you extend the approach to the transchoroidal approach, it makes it easier to dissect it of the internal cerebral veins. And so I certainly look to that on the MRI scan. Is this 100% sure? No, I think if it is dark, it is more harder. If it is bright, it is softer. That's the general rule that you can give.
I think maybe we ask the same question to Walid. Go ahead, please.
I just want to add one point that at times, and which is very, very uncommon, but some of them are having bleeding inside the colloid cyst. I have personally operated on 2 cases like those. The consistency was soft, very soft, but there was some blood, which gives a hyper intense signal on the T2. I have seen that. And I think this is one of the issues that should be taken in consideration. But I still agree absolutely with Professor Grodenois that the consistency mostly does not matter. And the previous classical teaching that if it is hard, then go microsurgically, this doesn't work. And I doubt that in any of the cases, most of the cases, that we need microsurgery anymore for this type of pathology.
That's a very important topic, why we don't have an opinion of Professor Alberto De Litala. I know that you had much experience about endoscopic treatment of colloids.
Oh, yes. Enough. I think that the best approach is endoscopic, and to go directly on the colloid cyst, and after then to perform a third ventriculostomy. I think in 80% of the cases we can remove quite totally the cyst. But also, if we leave a remnant, we can follow the patient and we can see in the ears. It's not so mandatory to remove all the cysts.
Thank you very much. Anybody in the panel would like to add any comments?
No, only agree with Walid that indeed we actually published 2 cases with one with an acute hemorrhage and one with an unexpected hemorrhage in it. So sometimes you have to bear it in mind when you deal with these cysts. Fully agree, Walid.
Thank you, sir.
We have fantastic cases there. Yeah.
Hisham, do you have any other questions?
Looking for what you observed, what's your observed recurrence rate for cystic craniopharyngioma that have been treated by aspiration plus minus Ommaya reservoir placement? I think this is a question for Professor Luca. I think
so too. Yeah.
Yes, I didn't get the question. What is this?
What's your observed recurrence rate for cystic craniopharyngiomas that have been treated by aspiration plus minus Ommaya reservoir placement?
Yeah. Okay. So we don't use this kind of strategy. As I showed, there was up to 70% of stabilization of the disease, but there were only 2 series, even though there were quite large series. I believe that the recurrence is 100% if you treat the cyst only with the cyst aspiration. With the reservoir, of course, you can have more chance because the reservoir you can perform as many tapping of the cystic fluid as you want. There is some differences between children and adults because in children with the adamantinosmatus variant, of course, you have the chance to have cyst, but the cyst can grow also laterally compared with the other cyst or the main cyst where you put the catheter. And this is what we observe even though when we use the bleomycin or the interferon alpha. So the long-term experience showed us that the cyst can grow also elsewhere compared with the main site where the catheter has been placed. We had some better experience with adults in the form where there is a large cyst. So we can also obtain a stabilization of the disease. So the recurrence of the cyst is as low as 40 to 50%, but in children it is much higher. So we cannot rely only on the cyst penetration of the reservoir. The reservoir is good to bring the child as long as possible, postponing the main surgery, then you can realize, of course, later on.
Thanks, Luca. Samer, would you like to add any comments?
Yes, can I add a comment?
Yes,
as Luca remember, many years ago, we published a limited series on child's nervous system, in which we proposed a transventricular, transcystic, and cystostomy with cisternostomy. So a catheter like the Ommaya, but without a reservoir, put it in the ventricle, perforing both the walls of craniopharyngioma and performing the direct flow into CSF flow into the cyst. And we had preliminary interesting results. Of course, it's not a definitive surgery, but to allow the patient to stabilize, or in all patients, no child, to allow radiosurgery. So is an alternative, mean invasive alternative very simple, very quick. And the recommendation is to wash 2-3 hours the craniopharyngioma.
Thank you.
Samer, do you like to give us some of your experience?
Thank you, Professor El-Ghandour. I have, whenever I deal with any of those pathologies, either college cysts or craniopharyngiomas, in the past, we as neurosurgeons, we used to make those decisions. Now we work as part of a multidisciplinary approach where I truly do not call the final decision without consultation with colleagues from neuro-oncology, especially for craniopharyngiomas. I was trained and worked with Professor Yastergill and El-Mifti, where in our programs, we always used to do gross total resection of all craniopharyngiomas. Now, some of them require gross total resection, but some of them require a little bit of, near total resection followed by watching, or subtotal resection followed by adjuvant therapy, or even watching, depending on the involvement of the hypothalamus, depending on preoperative endocrine deficits. So I salute all the colleagues who give excellent talks and different strategies to tackle and attack those pathologies, either craniopharyngiomas or college cysts. And I do believe that no technique is perfect, but perfect is doing the right surgery for the right patient, for the right indication.
Thank you very much, Samer. I think now, Hisham, anybody would like to make any other comments?
See one question, which is a challenge. Shortly, the challenge is shortly explain management of CSF leakage after operations. You can write a whole book. But anyone step-by-step management, maybe?
Personally, I think it depends on what you have treated. I mean, the CSF leak after a pituitary adenoma is different from an extended skull-based approach for a huge craniopharyngiomas. Generally, I'm in favor of reoperation rather soon. It's easier than any lumbar drainage, but that's personal opinion. I follow the Italian group who have the 3F, which means fat, flap, and then fast mobilization. Because we know when a patient walks around, the CSF pressure in the brain is very low. If you lay down, it's higher. So quick mobilization. And what I have experienced in my 40 years is that if you do a lumbar drainage and there is still an active leak, you can cause pneumosyphilis. I even lost one patient in my career due to pneumosyphilis after skull-based approach. So it's individualized. A small leak after pituitary adenoma is an easy thing to solve. With a large thing with extended skull base, we are still lacking the best technique to close what we have opened. I mean, we can make big openings. That's not an issue. We can open it easily. We do skull-based craniotomies below from the nose widely. We can open it widely. We still have not the proper techniques yet, and the proper to close it again in a way that we were always taught and used to use from above. That's the thing. I hope that there will have been some attempts, and I just can say it is as many things as has now been said, very individualized. So it depends on the type of lesions you were treating, the patient. If the patient is obese, for example, we know that the high BMI is so you cannot give one simple.
Actually, I think the best management is prophylaxis. Very meticulous closure spend really time and not fast operating and closing. Very, very important, because it's always a bad thing to have a CSF leak after surgery. And I think this is very important. And I think you can prevent a lot of CSF leaks or possibilities of CSF leaks by very meticulous closing and take your time for closing. I think that's maybe the most important step.
Absolutely wise said, Hisham, that because opening and closure is not something that you just do quickly and sloppy. These are essential steps. You start surgery with the best possible positioning. Never forget the essence of positioning. Then you perform the surgery, and closure is not something you leave the OR and leave it to your youngest resident. No, you do that. That is the essential part until the drape is on, until the patient is lifted. That's the part that where we can prevent complication. Take this as essential as the removal of the tumor. I fully agree with you, Hisham.
I think this, I think best answer to this question. I hope we have. Is there any other comment from the panel?
Thank you, Hisham. I think it's time to close the webinar. I don't know if Professor Diopojari and Professor Mahmoud, would you like to say something before we close, like closing remarks? Diopojari, can you hear me?
Yes, I can hear you. I think it has been a very, very good webinar, and I just want to congratulate you on a very good organization and thank all the speakers.
Thank you. Thank you very much, Mahmoud.
Thank you very much. I think I continue to say it's amazing how we can have international faculty of such high quality and high caliber give up almost half a day in their endeavor to continue to teach. And from a CAN's perspective, it's a godsend, because many of our trainees and residents and young neurosurgeons never managed to get to those conferences. They just didn't have either the resources or the time or the ability to do so. The fact that such eminent faculty are coming to their doorstep, literally, to offer them this kind of education, I can just, on their behalf, say thank you very much.
Thank you very much, Mahmoud. I'd like to thank Professor Diopojari and Professor Khorashi for giving us such opportunity to have this joint meeting with the Neuroendoscopy Committee of the World Federation. I'd like to thank all our distinguished speakers, Professor Alberto De Letala, Professor Samer El-Baba, Walid Aza, Professor Luca, Nassimi Alvaro Cordoba, Professor Andre Grottenhaus, and all our distinguished speakers. Thanks to Hisham for moderating this session. I would like to thank all attendees. May I not forget to thank my organizing team, Mr. Ahmed Magdi and Dr. Hassan Ala, for doing this great job. And I'm glad that this webinar is dedicated to Professor Fred Gentili, with all our best wishes to have a speedy recovery and to come back again and to join our webinars. Thanks to all of you, and hope to see you soon again in another occasion. Thank you very much.
Thank you very much.
Bye.
Thank you. Thank you very much.
Thank you all. Stay safe, please.
Thank you very much.
Bye-bye.
Thank you very much.
you.